So welcome to this Beacon conference, which is entitled Mobilising Collaboration Among Stakeholders to Optimise the Growing Potential of Tackling Cancer. I'm delighted to host this event in Warsaw, where I've been many times, especially on the issue, focusing on the issue of personalised medicine. How do we diagnose and treat patients earlier, but also how do we prevent a lot of the different types of diseases. So we have an exciting conference today, which I will come to. So we have 6 different sessions over 2 days, a day and a half. One is setting the scene. How do we bring innovation into healthcare systems? How do we facilitate public-private sector collaboration in the area? And this is really focused on incentivizing innovation and speeding up bringing innovation to healthcare systems. And then we have concluding remarks. On day 2, we're focusing on benchmarking in terms of how can we tackle cancer, especially an issue around disparities in cancer care. Then we have a focus on Central Europe, and then focus on Central and Eastern Europe, and then focusing on towards the European elections. The conference is very much focused on a multi-stakeholder approach, so we focus on bringing the patients together, clinicians, healthcare professionals, public health sector, as well as industry from the pharmaceutical, diagnostic, and IT area. So we have a first speech, is the welcome speech, where Rachel will speak first, who's the director of the Cancer Centre here. So I'm delighted that she will host us, has hosted this event. So I will give the floor to Baker, who's the first speaker.
Ladies and gentlemen, welcome to the conference at the National Institute of Oncology in Warsaw. I am very pleased to welcome the Minister of Health, Mr. Wojciech Konieczny, as well as Katarzyna Błądzik-Paskowska, Director of the Department in the Minister of Health. All speakers and guests. There are many other guests, so let me introduce National Institute of Oncology in few words. Every day I have the same problem. It's okay. South National Institute of Oncology, Maria Skłodowska-Curie, originates from Radio Institute, which was founded by Maria Skłodowska-Curie, 1932. Now it is the largest institute in Poland, as well as one of the largest institutes in Europe. This is the high-level references institute in medical field. The institute's headquarters is located in Warsaw. It also has 2 branches, in Krakow and in Gliwice, and some numbers of our institute. So, employee 6,000, scientists 224, 680, this is outpatient consultation, hospital bed 1,400. Follow-up patients 700,000, clinical trials over 500. It's really a great potential. The Institute conducts both clinical and scientific activities. Under our task, this is primary and secondary prevention, postgraduate education, clinical trials. The Institute discovers new knowledge in oncology and defines standards of care in support of the National Comprehensive Polish Cancer Plan. In 2017, we have created the first facility solely dedicated to the early phases clinical trials for oncology, and 2019, Center for Excellence in Precision Oncology. Our patients can benefit from personalized and diagnostic treatment in situation when standards are finished. National Institute is responsible for creation and implementation national oncological strategy recommendation and guidelines in healthcare system as well in clinical practice in Poland. National oncological strategy is based on the following assumption: innovation, innovation, education, patient education, our doctors, and investing in our healthcare system. We are facing the implementation of the National Oncology Network. Deadline is April 2025. Advanced work is underway on the criteria for entering the network, as well as the e-Vio card. This is a chronicle special card for the patient and for the doctors, and implementation of coordinated training. The network is nothing more than inter-center cooperation based on the references of the centers. So, no matter that how advanced our experience, we cannot develop without our patients. We develop international cooperation, cooperate with numerous international organizations, develop standards of conducting cancer treatment, and it is very important to develop platforms for scientific cooperation and exchange experience in this field. International cooperation will allow us to further improve and implement these experiences in clinical and scientific practice, as well as we can share them in numerous congresses and conferences. In the coming weeks, we will be honored by presence United States Ambassador and NCCN representatives. We will discuss further development of collaboration, especially in the field of creating recommendations and guidelines for the cancer management. I would like to mention National Cancer Institute. It's the only certified center in the field of the treatment of rare cancer in Poland. We also actively cooperate as a Comprehensive Cancer Institute, OECA. We are a leader in the Mission Cancer Program. We realize 5 projects as well as 3 projects in Europe's Cancer Beating Plan. National Institute of Oncology in Poland is the institute with the great scientific and research potential, as well as clinical potential, open to collaboration with all entities that are close to working for cancer prevention. So we would like to go there together. And I would like to wish everybody successful conferences, good time in Warsaw, good time in our institute, and thanks Professor Lugowska. She's a leader of our cooperation.
Thank you so much for all of you, also that you are here. Thank you. I hope that you will enjoy this conference.
I'd like to welcome the Secretary of State, Wojciech, from Poland, who will give an overview from the member state perspective. And it's key we have very much the stakeholders who are the key drivers, but the key is they have the political and policy support to really set the framework. And how resources are allocated in society is really determined by the political situation. And I'd like to welcome the State Secretary.
Honorable guests, distinguished colleagues, ladies and gentlemen, I would like to warmly welcome all of you to this unique event, which is being hosted in Poland. This is a great honor for us to have in Warsaw so many guests and experts in the field of cancer. I would like to thank the Beacon Consortium and the Polish Maria Skłodowska-Curie National Research Institute of Oncology for the invitation. Poland is aware of the need in increased action against cancer and fully supports all initiatives to this field. The oncology has been included in the priorities of the Polish Ministry of Health, which is reflected in the implemented program of the National Cancer Strategy 2020-2030. This strategy sets the patients sets the paths for the healthcare system in the field of oncology, pointing to 5 strategic areas to improve the effectiveness of oncological therapies and adapting system solutions to the needs of cancer patients. The main goal of strategy is to increase the percentage of people surviving 5 years from the end of oncological therapy, as well to increase the detection of cancer in the early stages, and to improve the quality of life during after the treatment. The implementation of the National Cancer Strategy makes it possible to reverse adverse trends such as fragmentation of care, dispersion of services and oncology centers, which have so far influenced the quality of oncological treatment and thus increase the chances of patients recovering from cancer. Inequalities of cancer prevention and care represent a key dimension of cancer control quality. Every effort must be made to provide fair care to patients, regardless of country, regions, or cancer diagnosis. The Ministry of Health of Poland is open to innovation, digital solutions, and advanced technology used. The transition to healthcare are intended to increase the quality, accessibility, and safety of the medical procedures. We work for the development of digital health services such as the online patient account and its mobile version Moje IKP, home medical care, health application portfolio, or projects using telemedicine solutions. Currently, over 80 million people in Poland have an active AKP account, and the Moje IKP application has been downloaded by over 2.5 million users. Almost 2 billion e-prescriptions and over 200 million e-referrals were issued. Digital services implemented so far, such as e-prescription and e-referral, have contributed to maintaining the continuity of healthcare. Ministry of Health plans to further develop digital services, central e-registration, patient short health card, and well as to further increase the number of types of electronic medical records and intensify their exchange, increase the reporting of medical events. All our activities are carried out with patients in mind to provide them with the best quality and professional health care. I wish you assure you that Poland is ready to build modern healthcare and public health system based on reliable data. Ladies and gentlemen, I'm sure the conference will be a forum for fruitful and interesting discussions and exchange of experiences, and will support the implementation of the Europe's Beating Cancer Plan. Thank you for bringing this fascinating discussion to my country. Thank you for your attention.
So thank you so much for the welcome speeches. I had some introductory slides at the beginning, so I will just go back to this quickly. So here are some of our great speakers. We have around 24 speakers, as you will see listed here. And as mentioned, we have over 6 different sessions which will deal with it, and the main focus is on tackling the disparities in cancer care. So Europe has invested quite a lot of money into this. Over 5 billion euros has been invested in European Beating Cancer Plan. Then there's a range of regulatory frameworks that are supporting this as well. So you have the revision of the in vitro diagnostic regulation, you had a clinical trials regulation, and you had the general data protection regulation. These are 3 key legislative dossiers that were supposed to improve healthcare systems in working, cooperating together. But unfortunately, when you look at the clinical trials regulation, there's a dramatic decrease in the number of academic clinical trials. The same with the general data protection regulation. This has caused a lot of difficulties in sharing and utilizing data. And in vitro diagnostic regulation, again, was supposed to help, and this has caused a lot of difficulties in terms of lab-developed tests. So Europe is well-intentioned in terms of what they want to do, and they've invested a lot of money, but the key issue is how can they best facilitate cooperation between different member states. And we have a range of different types of innovation that is being brought into healthcare systems, but the cost of cancer is dramatically increasing. And by 2030, it's supposed to be over 245 billion. So the cost of cancer is increasing. But we have a lot more innovation that has been developed to diagnose patients earlier. But the issue is how can this innovation be brought into healthcare systems? When you go to attend many different exciting congresses, you hear all about this innovation. Many of colleagues have presented in these congresses. But then this innovation takes a long time to get into healthcare system, and this is a big issue. Also, there's a lot of different therapies that are developed. But these therapies, while maybe approved by the EMA, the European Medicines Agency, they're not accessible in different countries. So this causes huge disparities in cancer care. The same with when we look at the different biomarkers that are provided linked to the therapies, then there's different types of ways these are reimbursed, whether from the public sector or the private sector, or not reimbursed at all. So this causes this disparity in cancer care across the main therapies, but also across all the different rare cancers. So this is a big issue. And then when you look at how cost is allocated in different countries, you have different types of costs when you're targeting different type of tumor types. So how costs are decided is different in different countries, which it should not be. It should be a uniform way to say, okay, this type of cancer this tumor should be tackled or prevented this way or diagnosed earlier this way. So this could bring better quality of life for the patient. So Europe then has invested through this mission-based approach, and it has 13 missions, 13 missions or 13 key targets there, how to tackle, how to implement the European Beating Cancer Plan. And it's on 4 key pillars: understanding cancer, prevention, early diagnosis, and early detection, diagnosis and treatment, and quality of life. And then one of these key projects that we have is Beacon, which is the focus of this conference today, where we brought all the different stakeholders together, focus on these disparities in cancer care. Another key project, I would say, is CanHeal, which we will hear about, focusing on cancer and diagnostics, as well as public health genomics. How can we bring genomics into the public health care field? And often public health is often overlooked. So how can the public health professionals support tackling cancer in terms of prevention and early detection? We saw it from COVID, public health professionals can play a bigger role. So they can play a broader role, for example, in screening programs, in breast, lungs, cervical, prostate, which were added into the council conclusions. So these are key issues that we're going to focus on in the day. To try to have more structure in terms of the presentations, I've asked different colleagues to focus on a SWOT analysis, looking at what are the strengths, so the many strengths in Poland, as you can see, great very friendly people, great weather, and a beautiful city. So, and also a strong cooperation, as we can see from the ministry that we just heard from now, and also from the hospital. So we want strong cooperation, develop culture, an ecosystem. Of course, the patients is essential, And then how do we have a scientific base? So this is key. But also the different weaknesses in different healthcare systems. So how can we overcome these? What are the opportunities that we want to tackle? And then looking at different threats in the area to overcome this. So in the agenda, we have different EU-funded projects. So the Commission has funded different projects. So we have different projects that will present how they're funding this. We have industry saying, okay, how can we bring innovation into healthcare systems? How can we have improved public-private sector collaboration to incentivize this type of innovation? And then we have different medical specialties from different areas, from the European Society of Medical Oncology, from the urology, from different tumor types, and then cancer centres. A key project is also Cancer Core Europe, which is around about 10 years, and that's focused on how do you build networks between different cancer centres. So as mentioned, we have these range of speakers. Some of the speakers already received flowers. Some, if they have very great presentations later, maybe they will get flowers as well. So we have to see about that. So the first, I will go swiftly to the first plenary session. So we're focusing on innovative solutions for bringing innovation into healthcare systems. And there's a lot of innovation as just mentioned, but the question is how to bring this innovation quicker and faster into healthcare systems. And it needs more cooperation between different healthcare systems and how we can do this, but also needs private sector and public sector collaboration. So we have 5 speakers here, and each speaker will follow the same framework from the SWOT analysis. So you have Ivona, from who received the flowers. She will give an overview. Then you have Tit Albrecht, who has been very active in the area, who has led a European Partnership for Action Against Cancer, when we were all less grey hair, and then with CanCon 1, CanCon 2, and now we have a European Beating Cancer Plan. You have Mark, who's from Science Sano, and he will talk about CanHeal, and he will speak many times during the conference as well. Roberto Garasso, who will give an overview of Beacon, and set out the framework around that. What is Beacon? I only gave you the name, but it's a lot more beyond the lighthouse. And then Tillman, who's from MSD, will give an overview how we can bring innovation into healthcare systems. So after each speaker, I will ask all delegates to ask some difficult questions. So if you have any difficult questions you want to ask anybody, you're free to ask. And then we will have a discussion at the end. So I will give the floor to Mark, who will be your first speaker in the first session. So Mark, the floor is yours.
Thank you very much, Dennis, and I would also like to thank the organization for the opportunity that you give us to explain CanHeal. But to my surprise, I only got 10 minutes and I have 21 slides, so I will rush through most of the slides. Now, CanHeal is a project within the European Beating Cancer Plan, where we try to, in fact, bridge between prevention, diagnosis and treatment. There was a call in the EU for Health within the Flagship 5 to address public health, genomics and diagnosis, new diagnostics and treatments. And with the people that we started, when we started to prepare response to the call, we thought we're going for 2 proposals, but in the end we merged them and we came to a proposal where we, in fact, had 2 arms in the same proposal, one focusing on public health genomics with a number of topics in there, one on the diagnostics and treatment, so let's say more the hospital, and we used use cases to try to bridge between the 2. We have some 15 different use cases, and during the process of the CanHeal, we also developed an evaluation model, a model that allows us to assess where we are for each intervention in the process to get it implemented into the healthcare system, taking into consideration the readiness of the technology, the evidence that is available, some cost effectiveness, the equities, and then there were some supporting work packages that dealt with quality, that dealt with the ethics and the legal, and also with the training of the professionals and the large public. So we had a meeting a month ago in Paris, so it's a short project, it's only 2 years, and it's in fact preparation for recommendations, advice to the Commission for the next steps, what we think is already ready, what could need some more research, what could be already going to, for example, in joint actions for implementation, things like that. And I will also make some publicity for a congress that we organized within the EU presidency of Belgium on the 28th, 29th of May in Brussels, where we will also present some of the recommendations that we already have at hand. The project will be extended till April next year, but there is already some things that we can put forward. I listed them here. One of the things that really came out is that we need some kind of an independent body that tells us where the technology is at. Not only the IVDR concept, but a body that tells you, for example, where is liquid biopsy now at to be used. So that was one of the things. Another thing is that it might be good that we start developing as a final output of the whole EBCP an oncology decision support system. And there I think we could bring all the initiatives together into something that could be useful for everybody and that could become a common. I would think some of you are aware of the Watson for Oncology initiative that was taken years ago, that was stopped, because you have to feed constantly the innovation into the system, which demands that the whole community is participating in the initiative. Now, just some words on to tell you how complex it is to get everything a little bit integrated with each other. I listed here a number of projects, and most of the projects Sensano is involved. Some of them still have to start, but a number of projects are already reaching to a level that we will have outputs, hopefully in 25, 26, 27, with real tangible outcomes that could support the further implementation of the EBCP. And I focused here on one of the joint actions that will be opened after the summer, the Joint Action Precision Medicine. And then you see all these different initiatives could feed into that. And so it comes a little bit from CanHeal. We will definitely build also on the parallel initiative on CanHeal that is called PCM4U, where shared risk trials are being, and new ways that clinical trials can be run will be done. We will build on Crane, that is now already have an extension, but I know that Tit will probably explain that a little bit. We will build on Jane, networks of expertise. We will build or try to integrate the imaging. We will try to integrate everything that's done on the 1 million genomes. So bring that all together and see where we then can go in a joint action on precision medicine and health, bringing that all into perspective and in line with the next steps of the EBCP plan. Here, just as information, the calls that will be open in the next quarter. It's a real challenge because it's becoming very, very rich what we have, but at a certain moment you have to bring that all together. And this together is not in projects, but in the real world. So it means in Poland, in Belgium, in Italy, in France, and everywhere it's different. So this is what in the next years we will have to start doing. They're all talking, everybody's always talking about synergies. The Commission, the GRC made a small tool where they, based on some, let's say, keywords, they try to see which project could link with each other. I made it for CanHeal, and you see we are already linked to some 50 different projects. I don't think it's possible, realistic, to have contact with all these projects. I'm not 100% sure yet also that whether we should make links to all these projects. But it's interesting to see on keywords what is interacting. So it's a nice tool, and I think it's a good beginning of something that we would really like to have and that we are developing in another joint action. Orion is a methodology, a tool that allows you to see what is going on and what is coming out and what could be useful for you and to whom you should address, where can you find information. Another thing, the mission is opening the partnership. We should align with the partnership, interact with the partnership for the gaps, filling the gaps where research is needed. So there's an opportunity there also. So these are the building blocks that I think for the joint action personalized medicine we have to bring together. So we have built on Crane, there's going to be a new joint action, the network of comprehensive cancer centers. So that will be the key partners in personalized medicine. You have the ERNs, you have the new networks of expertise. There is this idea of creating comprehensive cancer infrastructures. We will look at that in a later stage. Bringing the different players and stakeholders together is probably one of the ambitions of ECHOS, and I know that Hugo is here, we'll talk about it, I think tomorrow, Hugo. We are developing some solutions for doing precision medicine in the clinic with already linked to prevention at an affordable price. That's the aim of the OncoNGS project that we're leading. We have EUCARIM, we have the 1 million genomes that is now building a data infrastructure. So there's a lot of things that we have to bring together. And I think I made here, there are 7 joint action opening this year. So again, we have to see how we fit all this in. But just as a first idea, we have to bring in the drug. So the risk-shared approach, and Dennis showed already this difference in accessibility to innovative drugs. The drug could help in that, and where you start thinking also how to in fact develop enough evidence to convince member states, authorities, that there is really value being created, and that risk-share approach could be something that is running. Here you have the partners that is listed here. In parallel to the DRUP, to the PCM4U, there is a research project on new clinical trials, IDs. There also, I think it's a very important element that we have to think into. And this was just the first idea where we think in the joint action personalized medicine, next to the clinical arm, we should have an arm that looks from the clinic to the population, but also maybe towards the survivors, because there is also probably a need for a plan for precision survivorship, because luckily the treatments get much better, but the survivors still need some help, and maybe we see that there are a lot of things that are not optimal, and maybe some precision can help in that too. So yes, this is the list of the staff at our institute that is working on that, and that's, thank you very much. I hope I'm leaving you
21 slides in 10 minutes. That shows you the efficiency in EU projects. So we will move swiftly on. Any quick questions from colleagues? What are the key? What would you say is it? Oh, I missed one. Easier to.
If we are getting to the second step of joint action, you are talking about this precision medicine in second call, and huge perspective of joining so many activities around Europe. What do you see the role of the European Union, of the European Commission itself? Because I wonder how much can we do, like institutes from different countries, without the full support and engagement of Commission?
I think the Commission is already doing some things, and they installed this group, the steering group on cancer, where the member states are sitting together so we can do communication on the different things at that level. I think that maybe this steering group should be reinforced and get more involved in all what we're doing. On the other hand, we're running this project at the European level, but it's clear that you need to implement it in your country. And it's there that this interaction has to be built up. And I think ECHOS is already something that the Commission is trying to facilitate to help member states to get that going. But we have to see, and I think Hugo will explain a little bit, the different member states implement or develop these mission hubs in a different way. And it's there that you have to see how it works. And again, all the healthcare systems in the different, or the cancer care system in the different countries is organized in a different way. So you have to look at that, how to do that. It's not only the Commission who has to do, it's also at the local level that you have to see. But maybe the Commission could give enough means that at the local level you can have the time. But my personal observation is it's not only money, and we discussed it already a little bit, it's not only money, it's also time. And it's sometimes, I have sometimes the impression that what we're doing now is going too fast. And the healthcare, because, for example, the implementation of the use of omics in the healthcare system in Belgium, that took just the preparation 5 years. And now we're running a plan for everything in 7 years. So, but I think we have to take the opportunities and then see where we can get. And then the important thing is, and that's what I always had with the joint action, because sometimes in Belgium there is critics on what is the usefulness of this joint action. The usefulness is that you create a community in Europe of people that are able to exchange experience, best practices, and work together. And this definitely is something that honestly I think we are the only continent who have that. I don't think it really exists in the United States. I never heard about it in Asia, Africa, Arabia. So that is the real strength. And you will see in the coming, after the EBCP plan, you will see how strong Europe will be in the field of cancer. And I can already tell you, in the field of rare diseases, people are getting jealous. So that is, but I think to answer your question, the Commission can probably help you in having a structure funded for implementation through a project like ECHOS, and maybe we should have another one.
Thank you, Mark. Any more questions? Hugo? We have to see. So our next speaker is the lady from the flowers, it's Ivana, who's she has many hats, as you can see. This hat she's wearing now is the executive secretary of OECI and a board member of OECI, which you tell us what OECI is. So, take the words away.
Yes, indeed. So I've got at least two roles. So first of all, I'm coaching this event with Denise. So thank you very much, and so of course thank you that you are here together. However, on the my other role is also to be executive secretary of OSCI, Organization of European Cancer Institute. And here will be a few slides about how this organization promoting innovation for quality in cancer can also take into account solution that we would like to bring in healthcare. As an organization, I would like to point that it was founded in Vienna in 1974, so it's almost as old as me. However, during this time, this is a huge network of the most prominent sites of cancer centers in Europe, and not only. We've got also some representation from South Africa, Chile, Colombia, Jordan, Tanzania, Turkey, and other countries as well. What is important that this 150 institution from 42 countries build this strong network, and this network, as you can see in Europe, because also during this meeting we will talk about disparities and inequalities. As on this map, we can see different dots. Perhaps on this slide will be easier to show. So there are some stars and just circles, blue one, the blue one. So blue circles is just a number, and those with the star, this is the site with accreditation. And this is important also to see where those stars are right now in the most prominent way. So definitely Central and Western Europe. In Eastern Europe, it's not that much. The goal also of our organization is to unify and to provide patients and our community the multidisciplinary and personalized care approach to reduce mortality and to guarantee the equitable access to care. So this is the number one of our aims. And as well as without comprehensiveness and multidisciplinarities, it won't be possible, because to treat cancer, we just need to collaborative work with different disciplines, especially right now with the innovation. And of course, improving quality and internal organization of our members, it's important to support not only our building a network, but also to support basic transitional clinical research and to strengthen collaboration. I will talk about that. So this is the structure of the organization. And it's important that this organization, with the president, we have also our Polish representatives, Professor Kumakowski. He's not with us, but he's still active and probably as active in terms of his support for me as it was before. Nevertheless, I've got the pleasure to be in board and also as executive secretary. This is right now the representational board, but during the within next month in June in Helsinki, we would like to also increase the composition of board. So this is the proposal, and the idea was also again to think about to make equal also access to giving voice during the board meetings. So we try to look at the Europe and also to propose the members of board from different countries, from south, north, east, west, and central, and also taking into account other aspects, like for example gender. So as an organization, this is 4 working groups. And also because of data, so we have the cancer outcome research, because outcomes, it's majority, this is the critical part of the monitoring our effectiveness. If we know that we are better, then we can reduce mortality. And again, the molecular pathology and the innovation related to diagnostics is a part of the another working group, and collaboration with patients, and as well economics. It was also pointed before that economic aspect is critical. The needs are not only in terms of patients, but also in terms of payment going together. So important also for us is to keep the quality of this care and research. And one of the flagship activities of this organization to do it and to leverage inequalities is an accreditation and designation program, which is focusing on delivery high quality care, as well as consensus-based patient-focused standards. Based on this accreditation program, we need also to look for multidisciplinarity, as well as experience of the sites and benchmark comparison showing best practices. Education and partnership in collaboration with other partners is also under the review. So you can see the circles over there, and we are talking about the OSU Cancer Center, and we are talking also about the OSU Comprehensive Cancer Center. And this comprehensive means that this is a huge also role of research where we can find in this program. So at least you can see domains where we are searching for quality standards, not only governments, but also patients' involvement, multidisciplinarity again, prevention and early detection, and we can go through the process and patients' pathways because of diagnostic, because of the treatments, and of course research and education. So general principles, as I mentioned, it's a peer review program, and you can see here on the bottom that right now in Europe there is 34 comprehensive cancer centers, 19 cancer centers, and this community also built a network. So it is not easy to do such kind of program to be sure that we are on the way in terms of the organizing the right approach and right measurements. As I mentioned, the organization is almost at my age. So for all of this process, the program, there was working together on a collaboration with different European cancer organization, with patients association to develop this, and also to build a community of people responsible for evaluation, accreditors, which is a number almost 100. And such program takes around 2 years. And to be accredited, this is timelines for site. And on the other hand, it's possible to do with these resources to give accreditation to around 5 sites per year. So it's quite time consuming, it needs a lot of resources, but it's already with a huge experience with this organization in place. And of course, the publication, if you're interested, you can go into the site. However, I would like to come back to data. I would like to also to come back to capacity building, because to have data, it's nice, but on the other hand, do we have enough capacity? And the capacity is on a right, mature way to do it. So at least as an organization, we are present in different action organized by European Cancer Plan as well, Mission Cancer. And what is important, this is the project that OSOS leader, is the project CCI for EU. And as we know, the one of the importance of European Commission in terms of improving patient survival is to build an appropriate comprehensive cancer infrastructure. The name of the definition is not easy to understand. However, at least based on Mission Board and US Mission Cancer, they defined as a national or regional infrastructure that provide resources and services to support, improve, and integrate cancer care, research, training, care professionals, and education for cancer patients, survivors, and families. So it's complex. However, it covers everything in terms of which is related to cancer. So at least comprehensive cancer network, we can see comprehensive cancer centers, and the clinical cancer centers, research institutes, units of general hospitals, diagnostic units. So it's just infrastructure in each member state, quite complex. Nevertheless, only as an organization, as a perfect organization of this network, we will be only then possible to reach our goals. So at least you can see also the different aspects of the program. If you are looking at the different solutions that are already in place, usually we need to concentrate on one hand on the care, but also the focus on developing research and innovation capacity is critical. And this project is about also how to develop this research capacity. And as you can see, the Europe looks quite impressive. So right now in this project we have the representation of almost each member state, and it's why it's important also to collaborate with the different local initiatives to make it to find synergies, to unify, to find the solution that will be at least in the same direction that's in other countries. More information is on our website. So about this actions, probably some of you are also present in Helsinki meeting Oncology Days next month, and we will be also discuss how to be even more effective in terms of the and how we can use this infrastructure of our members to bring the high quality and also the tackle with data, because it's not easy for all of us, as we heard before. Legislation is one of the obstacles, but it's not the only one. Thank you.
Thank you very much. Well, it's hard to be more effective than we have here in Warsaw. So, but we can see what will happen in Helsinki. So any questions? So how can we build the capacity of cancer centres in Europe? What is the biggest problem do you see? What should Europe do to build the capacity more effectively across Europe?
I will start with the conclusion. So if we have concluded that we would like to reach the point and then reduce mortality 20%, 50%, at least we need to measure. If we cannot measure, then we cannot also be sure that we have a right direction. So to set up the right KPIs, to set up the right processes that will allow us to see those KPIs at the end, and also to build this infrastructure, because to have data without structuring those data we have, without access to this data, we will never be sure that this is the right direction. So one of one of those issue is just to define what we would like to have, what we would like to measure, how we would like to measure, where is this capacity. And also, this is the one aspect. It's of course as complex as the project that I show right now, and also Mark showed you in the previous presentation. It's a lot of actions. There's also joint action. We have already came, so I'm very happy to see it. Hello, and we have Jane and Salvatore. Hello. So at least this is something what we are doing, and what is also important, just to understand what's going on in different projects, just to be sure that we have the similar output and we do not duplicate work. Of course, it's better to say not to find synergies, but I prefer to be more straightforward, not duplicate.
So data is key, as you mentioned. So how do we value diagnostic information or utilizing data? One is in consolidation in terms of how we bring different cancer centres together. But then there's a big issue of healthcare professionals. We have a big shortage of healthcare professionals, like pathologists, and how do we look to bring innovation? So Europe have more of a focus on industrial policy for healthcare professionals to take on the skills that we need to operate these comprehensive cancer centres, or do we have skill sets there?
Because I'm the third role, I'm head of early phase clinical trials in this hospital, and I know how it's difficult to find the people motivated who would like to tackle with cancer, because it's a challenge. It is demanding, and sometimes you are a little bit underpaid than in other specialties. So we just need to come back to students and show them the benefits to be and follow our footsteps. So I think this is some kind of relation, because at least then with the appropriate solutions for the young people, and we can have more resources. I know that we have a shortcut. It's very painful, especially when we in this region we educate. We just have a lot of great students. I'm happy that they want to go abroad, but I'm more happy that if they want to come back, it's not that easy if they need to come back and to find not that great opportunity. So this is a very typical situation, when we compare salaries, when we compare resources, when we compare education.
Thank you so much. Next speaker is Phil Albert, and now the direct flight to Warsaw. So for those who are coming back, we can take a direct flight. Phil is the scientific director of public health is a key issue, and he has led many different EU projects over the years. So I have some difficult questions on that later on. So I will give the floor, and here's the.
So, my task is to introduce briefly the Joint Action Crane, which was mentioned several times today. It's actually closely related to the activities that Ivona has just described, the activities of certification and accreditation of comprehensive cancer centers. So basically, it is a project that lasts for 2 years. It will finish at the end of September this year. And as you see, there are several objectives. The first one is to prepare a framework for the basic set of standards and criteria for the future CCC certification, prepare the organizational structure and management and development of the network, and address some of the organizational and practical challenges in the establishment of CCCs in different member states, including their different realities. This has been mentioned several times today, and I will come back to that. There is some piloting done, especially on CCCNs and their links with CCCs. And importantly, we are developing 2 instruments for the future network. One is the development of the so-called maturity model. This is actually done in Poland with our colleagues at the Public Health Institute, and the blueprint. So I use the template that you suggested. I think it's important to reflect on our own work, because this will also maybe give rise to some of the discussions, not only after this session, but maybe later on as well. So what are the strengths? One thing that I have to stress here is that the decision to establish the EU network of comprehensive cancer centers was a political decision. Because many people who did not understand how these things work thought that this was actually the idea of the consortium that is now developing the project. But this is not the case. This is something that was written in the Europe's Beating Cancer Plan, and this is a fact. So if somebody wants to change that, they have to go through the political process but actually this was taken up for the reasons that already Ivona described quite much in detail. So there should be a collaborative network that will connect the leading cancer treating and research institutions from all member states. What are the weaknesses? Of course, for many EU member states, this is a challenge, because what is written in the Europe's Beating Cancer Plan also says that every member state should have a comprehensive cancer center. And we know, for the reasons described indirectly by Ivona, by implementation of standards and so on, let's not forget, Poland is a relatively big country. Maybe you don't think about yourself in those terms, but we have member states that are tiny. Malta, Luxembourg, Cyprus, some are islands. Also Estonia is not huge. And there are some countries that are sort of small to middle size. For such countries, developing their own CCC is actually not feasible. But they should still join this family. And there will have to be solutions for that. Of course, it's definitely the fact that the establishment of CCCs is one of the contributing factors to better quality of care, but of course, by far not the only one. There are other reasons, other instruments that we have to respect. What are the opportunities? We are launching the processes of quality assurance and improvement in member states. This is probably, so the outcome for us should not be the establishment of the network, as some of our colleagues have already said, but actually improved quality that we should measure, and of course to raise the discussion of the organizational aspects and involve the processes in order to achieve high quality and also safe cancer care. One of our colleagues from one of the smallest member states repeatedly asked me, "Pete, but are numbers important?" And I said, well, in medicine today, numbers are important. You cannot escape that. If you have criteria that are quantitative. They are expressed in numbers. Also, of course, there are some that relate to processes. We should aim at cross-border and international collaboration in cancer care. We have good examples already in some cases. We have European reference networks. We will have networks of expertise. So these are the synergies we see for the future. Of course, there are many shortages in institutional and workforce capacity. Ivona has just reflected on that. To meet all the challenges when you restructure care, sometimes there is lack of political support nationally. We should not forget about this. The whole concept, the scheme that you have just seen a few moments ago, shown by Ivona, of course requires important health system changes. And of course you have to have the willingness of the policymakers to enact them. Of course, there are objections to changes. My primary, how shall I say it, irony is that those who object changes actually object high quality of care in oncology, because today you cannot imagine not being exposed to research. Sometimes there is lack of public funding for research and for development, and this is sometimes a huge challenge. How should we ensure sustainability? Establish the network together with formal functioning and definition of longer-term financing. Work closely with competent authorities, which are mostly the ministries of health or other key institutions at the national level, and continuously develop the solutions in response to the elaboration of the maturity model and the blueprint, which will be instruments to support the development of the network in the future. What are my final thoughts? So EUNet CCC, I'm bringing in another abbreviation, I'm sorry, but you have seen many today already. This is the official name of the network and also the joint action that we will launch. The project will be launched in October this year, and the network should be launched by the end of 25 or maybe early 26. We will see how quickly we can meet all the requirements. It is an opportunity to strengthen the link between care, research, education, and training. When I was finishing my medical studies, there was still the reference to the so-called routine care. So if I do routine care, I don't have to listen to these strange researchers and so on, who only spend a lot of money and fantasize about very expensive treatments and technology. But this is, of course, totally outdated. Today, we have to secure the translation of research findings which have been evidenced very quickly into clinical practice, otherwise we cannot ensure quality. Professional development at the member state level, of course, is also one of the challenges in this sense. Convergence of standards of care. One of the benefits of the processes that have been running under the auspices of OECI is actually the accreditation process is actually the convergence of standards of care. And this is, of course, an important process when you introduce standards, when you introduce certification, accreditation, and expose professionals to translational research and strong development of networks. Finally, cross-border collaborations and links to the existing EU networks, including ERNs, but also the ones that are being developed by Jane, and working together with also professional associations and other professional societies, obviously including OECI, German Cancer Aid, which is another only national institution, but an important partner also for the development of comprehensive cancer centers in Germany. Thank you very much for your attention.
Any questions? Yes.
Thank you. Thank you for the presentation. You talked a lot about creating the link between research, care, education, training, which I couldn't agree more. One of the basic elements to make this linkage seems to be data, and data that is possible to share, access, and reuse for research purposes, be it clinical research or technological research, especially AI development. To which extent is Crane supporting or doing something to enable data sharing, to facilitate data sharing? We are all aware that this is a very difficult subject, and for many different reasons. I will also speak a bit about this. But is this something that is in the agenda of the project, or is it on the side?
Thank you. Of course, this is not on the agenda. You have seen some of the budgets. The budget of Crane is half of the budget of CCI for EU. So some of the projects do not enjoy such strong investment. I'm not complaining about that. It just the focus was not on that. We are stressing the importance of both population and clinical registries. This institute, I know it very well since I was collaborating with different professionals from this institute since more than 20 years, has the benefits of registries. And this is why they can show a lot of evidence on their activities, on their performance, and so on. And I'm still very often surprised that, you know, countries start and launch screening programs, and then you say, so how will you measure the effect of the screening program? And they say, well, we will see a little bit about the incidence and mortality and so on. Yes, but where's the link to the registry? Ah, well, you know, we have problems with the registry. I hear now, because you come from Greece, that now finally the government gave support to the establishment of also the population registry and so on. So this is extremely important. And I think the data is essential, because we cannot take decisions on our impressions and feelings, or only on qualitative information. So I think there are other processes running in Europe. The European Health Data Space project, sorry, not only project, a directive, and other activities on registries that are extremely important in that sense. So this is not to be seen as a separate activity, but we couldn't cover all the topics.
Any more questions? I have a question. Yeah. So Europe funded European Partnership for Action with Cancer, Canton 1, Canton 2. What's the big difference between these platforms and a European Beating Cancer Plan? And linked to that question, why should Europe keep funding these initiatives in the next legislative period?
Very interesting question. Well, these projects were omnibus projects. They were projects covering everything from health promotion to palliative care and everything in between. They tried to streamline some of the important topics. For those of us who have a longer memory of these projects, and while you are certainly one of them, what has come out of these projects? One thing, European Cancer Information System was the result of the first joint action. National comprehensive cancer programs were linked to the development of the first joint action, and their development was strongly supported by the Commission. Then we had the activities, the definition of survivorship, the activities in palliative care. Furthermore, comprehensive cancer care networks, their definition, conceptualization was one of the reasons. We discussed inequalities. We had 3 joint actions evaluating scientific evidence on screening programs. These became inputs also to the work that was then finished by SAPEA Group and culminated in the new recommendations. Finally, now your final part of your question is, the Commission has mobilized a lot of money, but as Mark stressed in his speech, now in EBCP there are some sub-remarks which some people don't exactly understand. For example, I will give very practical examples. If you want to reach 90% coverage of the target population in screening programs, who is going to finance that? The member states, please. Let's not forget. This is not going to be financed. Yes, some activities, conceptual and so on, will be supported by the CAN-SCREEN joint action. The processes of the restructuralization of healthcare to incorporate research and to develop comprehensive cancer centers and networks will have to be financed by the member states, more or less totally. Our next joint action will enjoy the biggest budget for such a project so far, 112.5 million euros. But of course, we have 31 countries participating. We have 15 national pilots. We have a lot of activities in front of us. So when you break it down, it doesn't sound so much money anymore. But of course, for us who used to work with projects of less than 1 million euros for a long time, this is of course a huge sum of money. I think that the creation of the thinking that you need to mobilize different stakeholders, and I'm sure that Hugo will go into that, also nationally, is extremely important. And I can confirm that this has happened also in Slovenia. So how are we going to reach the CCC? By creating a network between the Cancer Institute, the 2 university hospitals, the 2 medical faculties, and the chest hospital in Brunei. So this is something that in the past looked as, you know, impossible, but now we use the driver of these initiatives also for the national purposes.
And you have one question, Nicolas. You mentioned all the stakeholders. One key stakeholder is also industry, because they bring a lot of innovation. But often there's a disconnect between the public sector and industry collaborating. Can the innovators collaborate, cooperate with the
Joint actions are intended for public entities. So joint actions are policy projects. And let's not forget that in Europe, cancer care is financed from public funds. I will not claim 100% because that's not true, but to a much higher percentage than across the pond.
Thank you so much. Any questions? So our next speaker is Roberto Grasso. So we mentioned Beacon, and nobody knows what Beacon is yet, unless you read the one-pager, which my colleague Anna prepared. So Roberto Grasso will give an overview, and he has a big team from IEO. And I hope he followed my nice template.
Maybe. Thank you, Dennis. Thank you all. I'm very excited and happy to be here, also for the Beacon project. And I will give you a short overview regarding the project, but also I will give you some results from an area that which is not too much explained, which is psycho-oncologist. I'm a psycho-oncologist by background. So it is something we talk about genomics, we talk about data, radiomics, and I will let you know something that we came up from our focus group with passion in some country. So Beacon is a youth-led project. It's last 2 years and will end at the end of October. The IO is the coordinator, Professor Gabriella Pravettoni, which is a psycho-oncologist as well. And we start from the Europe's Beating Cancer Plan, of course, and the major tool that we have to reduce cancer disparities, so screening, treatment, access to data, but measure to access to information, so access to relative information for patients, especially for rare cancer patients, which are spending a lot of time to find which is the best center for their specific treatment. So we apply to this call, which is focused in mapping capacity and capabilities of the Comprehensive Cancer Center. And also we link that with reducing cancer disparities. So we are trying to get as much as not data, but metadata. So public available information, but also results from other data. And we try to aggregate all this data in one depository. So we focus on mapping all these capacity and capabilities to achieve also the treatment, the screening, the quality of life, but also the palliative care of the cancer patient trajectory. And we focus on OECI Comprehensive Cancer Center, so we had also a support of OECI that support our project. And this is something that I already discussed with Rowan. We try many times to send all these, our repository, which is a wiki, a kind of Wikipedia, and tomorrow Ali, my colleague from Sport Data, will explain better what is that. Is a wiki, and as a wiki, everyone can get inside and try to modify and say this is true, this is not true. And we send many times to the OECI Cancer Center to ask their support, but unfortunately no answer so far. These are the main aims of the Beacon project, which is mapping capacity and capabilities, but also get all the metadata that we collect in one repository, and after create a decision support system that will help patient, researcher, policymaker, but also clinician. As you can see, this is our final product, our main aim. We are developed. I will show you a mock-up at this presentation, but also Aline will talk about that tomorrow. And this decision support system will, chat with the wiki, with the repository, and help patients in their decision treatment, but also allow policymakers to allocate funding for the real needs, but also researchers to share data, and clinicians to have a second opinion. And this is, as I told you, like we are trying to link the mapping of the capacity and capabilities with the inequalities. So, for example, if in some country there is a high level of death for some pathology, some specific pathology, that will be linked to the quality of also the screening program or the treatment for that specific cancer in this specific country. And as I told you, we did some focus group in Italy, Slovakia, but also in Croatia, which are not, there are not OECI Comprehensive Cancer Center that, and we come up with some interesting results. So they are seeing disparities regarding psycho-oncological support, but also geographical disparities, and also bureaucracy, a lot of waiting lists, but then also the cost. So in some countries there is private insurance, so there is not public, and there are not available screening program integrated with a cancer system. And starting from that, as I told you, we are psycho-oncologists, we are very interested in what are the main outcome for in terms of emotional distress, so depression, anxiety of cancer patients, as it affect not just the patient in their cancer trajectory, but as you know, affect also the family. So cancer is a family illness, so affect all the members of the family in terms of timing, but also in terms of qualitative of life. And we start with this paper which was published with my colleague Veronica right there, and it's a prospective one. And we come up with some interesting disparities regarding psycho-oncological support in terms of economic allocation of funding of some countries. Just the 37% allow funding to psycho-oncological support, but also in terms of cancer type. So we found out that breast cancer patients are more allowed to get psychological support regarding prostate cancer. That's maybe also for some specific themes that come up to the consultation, like sexuality or something like that. But also, you know, there is a theme of certification and accreditation. So there are not guidelines of psycho-oncological support, and also in different countries there are different, I will say, clinicians that practice support, so psychotherapists, psychiatrists, social assistants, and something like that. And also some geographical support, so not every clinical cancer center have their division, so to get support in a cancer patient. And we get all this information that you can see here, and gave to inside the decision support system that we are going to develop. So this is the decision support system. So you can see this is divided in the 4 main stakeholders, and we are trying also to get geographical allocation of where the patient, for example, go inside to the decision support system, so we can map also all the 4 stakeholders. In these last 5 months, we are working in develop, but also in getting user experience, but also in usability of this tool that, again, my colleague Aline will explain tomorrow for sure better than me. And that's pretty much all. So these are the partner of the consortium. As you can see, we are a small consortium, but with European Alliance of Personalized Medicine, and also University of Palermo, Sprudeta, which is our technical partner, and the University of Zagreb. Thank you.
So any questions? So we have one question from Julia. Any questions from ladies? Yes. Okay, so I'll go for Hugo first.
Thank you for that presentation. Thank you for the nice presentation. I was wondering about your first objective of mapping the capacities and capabilities of these centers. And don't get me wrong on the question, is really curious and wanting to know is what differs this mapping from what is being done in other projects such as the CCI4U or the OECI mapping of, so are you mapping CCIs and their CCCs and their competences and capabilities? Is your mapping also extended to non-cancer centers, just as general hospitals who have an oncology department? And since you are both mapping centers, how can you collaborate, or how do you complement each other's information?
So, first of all, thank you for the question. So, we are mapping just OECI Cancer Center because as before Ivona explained very well, they are a high standard of accreditation, and also because in a very simple matter we had this support, and we thought it will be easy, to get some information, but not just information about the standard of care in each hospital, but also regarding some administrative information. So how is along the list for breast cancer screening or something like that. We are mapping metadata, so not data. We are mapping information regarding data, but also public available information. And this mapping was done through some public database, but also going inside some, for example, in IO, we are website which is quite good of information regarding how many patients was treated during the last year, how many intervention, how many screening program, how many psycho-oncological support regarding, for example, our division, how long will be the list of obviously not every cancer center has these details, so that's why we try to get information from the center themselves, because as the wiki, with the Wikipedia, you can, in the Croatia, go inside and edit it. So I don't know how we can improve this collaboration. That's something that I discussed before with Ivona. So, and we sent a few emails, but maybe also the person that are in charge of the Comprehensive Cancer Center they don't know they don't have every information. They have some specific piece of that. regarding collaboration, I think that's why we are here. So, you know, to discuss about that, to think how we can integrate and merge all these data sets.
If I'm allowed for a second
Yes.
question, would it make sense for, for like, I don't know, a second stage that you expand outside OECI because you have hospitals that are not OECI certified, cancer centers, general hospitals, but also those that are certified by the German system or something like that? Would it make sense, or do you envisage that
I
step?
think it's make a lot of sense because there are not just different between OECI, Cancer Center, and accredited and not, but also inside of the country, for example, in Italy, there is a huge difference between the northern hospital and south hospital. So there is a lot of you know, travel cost on people that are moving from the south to the north. So it will make a lot of sense, but it will be very, very difficult also.
Yes, and so I would like to come back to the decision support system,
Yes.
because there was different players. So of course, I assume it's for patients definitely, but it's also the kind of, you know, solution to prevent the burn syndrome for medical professionals within the solution.
That's for sure. So if I understand very well your question, so regarding the physician, so
Yes,
how
exactly.
they can use the decision support system.
Yes, to prevent burn syndrome, because it's a challenge to be oncologist.
Yes.
And at some point, when we've got a success, we believe that we are doing right. But at some point, with a lot of failure, we just also need to, you know, to protect ourselves, to still believe that we are doing right. So, is the solution and the support system you are developing also address this issue, that can be a part, or it's only for patients?
No, it's not only for patients, it's also for clinician, but also, you know, to get, especially I think for regarding also some project with Salvo regarding rare cancer patients. So they are, you know, many professionals need to, you know, to get some second opinion or get some information regarding some specific rare cancer. Solid sarcoma, but also pediatric one, hematological cancer patient. And so this is, I think, this decision support system can help to bring, you know, synergy between physicians that are working in a sport center and also physicians that are working in a hub center. So, yeah, I think
any other questions? Okay, so thank you.
So in this regard, the problem or this kind of tools is also the fact that federal policies are not, unfortunately, a matter only for physicians or for patients, but for policymakers as well. So when touching these issues, we must consider that any health system organizes its own way, and also consider this kind of referral policies. For instance, in Italy, one of the things we had to face building the Italian Rare Cancer Network was considering that we do not only have a national health system, but also a regional health system. And so the regional health system may not be happy if you suggest, for instance, a patient from one region to move to another region to be cured for a specific cancer, because it's like the region of province of the patient will have to pay another region, another health system to cure that patient. So it's very hard to find the right way, but this is the reason why, again, we are here and really regards equity.
Then we have another question from the young man. Second row. Really important question.
Well, in the preparation of the new project, I had an interesting discussion with colleagues from Spain. The government decided to follow up on the recommendations of the Europe's Beating Cancer Plan by recommending the establishment of one CCC per what is called in Spain Comunidad, the region. And now, of course, this is probably familiar to you, Roberto, because of the power that is concentrated in Milan. So Madrid was upset. They have their own network, oncological network. Some people say that it's not very active, but nevertheless, they have a consortium of 28 hospitals that treat cancer, and they are not satisfied with one single center. And the second problem is that the weight on the cancer care in Spain, for example, was not on cancer centers, because that was not a priority. It was on the university hospitals building networks. How do you see that? Is there really a need for them to transform the system, or whether it is better for us, all of us, to show some flexibility? Thank you.
Actually, also in Milan there is some university hospital network. So, and I'm sure that we need some flexibility for sure to come up with, you know, some good point for passion for sure, but also to have some guidance for the clinician, also for psychologists as well. That every cent we saw like we host also the IPOS Congress in Milan this year, and so every country are going with themselves. Some network in some countries think that psycho-oncological is you know, giving psychiatrists and pharmacological support rather than psychotherapists, and also in psychotherapists we have different way to treat depression, and so we need some flexibility for sure.
Yeah.
From Spain.
Yeah. So we come from Spain. So sorry, my voice. I agree that we need to have some flexibility in one side. In the other side, and I hope this is not being recorded but I think that we need to have a mandate from the European, from Europe, not saying the European Commission, because this is being arranged among the member states. Because, for example, the case of Madrid, and we are from Madrid, even if we are working in Barcelona, is that there's too much fragmentation, and it doesn't need to contaminate the models. Is precisely the opposite way. So I agree we need to have some flexibility, and maybe these networks. For example, in Madrid, we have a center that has proton therapy for pediatric oncology that needs to be included, even if it's not a great comprehensive center. So we need to have some flexibility, but I think that they have to get adapted to the European mandate. Otherwise, it's going to be one case scenario in every country or every region.
Thank you so much. Thank you, Robert. Quite good timekeeping, relatively speaking. So our last speaker in this session is Ferdinand Huber, Director of Oncology from MSD. So I have one stakeholder conversation, but also the industry as well. So he will talk about that.
The industry was not a partner, obviously, as we've heard, but an interested observer, maybe, if that's the right term, and hopefully also, at least at times, making a contribution to all of this. So thank you very much for the invitation, and thank you very much for the opportunity to still speak a little bit from the outside, but again, interested. And what I would like to do, obviously I don't have a project to report on in that sense, but I was intrigued in the preparation of it, but then also going into this and into this first session especially. a lot of talk about the need for good and better data, better integration of data, and I think another topic that struck me really is this alignment and integration between the different levels, and so like working with the fragmentation of the different healthcare systems across the levels and trying to find better ways to implement some of the good initiatives that are being done at the EU level that you're all working on and engaged with, and that are really great to see, but that sometimes probably cannot come to the full shining because there's a lot of inefficiencies and loss. So what I'd like just to offer a little bit is a little bit an outside view from our end, and maybe also give a little bit of glimpse into some of the topics, recommendations, proposals, and sometimes probably demands that we are also voicing towards European and national, especially policy decision makers in our case in this one. Where we are coming from is this understanding that I think you all share, and that we can all see, and that you're all contributing to so much, is that there really is a lot of activity in the area of oncology, and there are a lot of really beneficial developments that have taken place, but also this deep recognition, and we see this very clearly sometimes in our sales data, but more importantly also from some of the discussions in the countries, that not everyone has access to our innovations of our industry partners, and then also to the whole care spectrum that healthcare professionals provide to patients across Europe, and as we've just heard, also within European member states and the countries. And I think this ambition is shared, and it's good to hear always that there is this goal to have the right treatment reach, in our case, reach the right patient at the right time, but also that there are a lot of gaps still, and a lot of improvements that need to happen there. The reasons for those different degrees of patient access, in our view, are really various. I mean, we always come back, of course, to lack of or delayed reimbursement systems, and what we claim to be regulatory lack of flexibility, maybe at times, but it really goes further, oftentimes, and I think there is this recognition. Preparing coming here to this beautiful city, I pulled up an example from Poland where we did some own research not too long ago, where we saw that even though there is a reimbursed treatment, and even though there is access through reimbursement to the treatment, and the treatment is sort of like listed in the guidelines, and there would be access to this, we can still see huge amounts of variation. And I've included that example here. This really is the ambition that this should not, cannot be, must not be. The question is, what is it that we can do? I also tried to follow Dennis's SWOT analysis template to not fall out of the good lines here. I think, and you're all much more testament to that than I could even imagine. I mean, the strength really comes from a persistent and continued momentum over the past years, where Mark stressed this very much and very passionately, so where we can see really increasing this from European regulatory framework and cooperation at the EU level, but also in the EU member states. And I think that's something that simply must continue, and I'm pretty hopeful that this will continue. Of course, the big weakness that goes against this to a certain extent is the fragmentation in and of healthcare systems that we just heard about in the discussion, and that remains a challenge, and that you all deal with so much, a bit like us also at times, if you can say that. I guess what's needed, and that's also the opportunity, is to come up with even better governance structures, and really to focus on the implementation of the European Cancer Plan, but also of a lot of the initiatives around that we're involved in, and maybe to turn the debate a little bit around also to try and work on the creation of incentives for good governance, for smart spending, and for thorough implementation for the coming legislative term. The big threat that I see, at least, is that we sometimes, I think, get a bit dismotivated and discouraged by a lot of the fragmentation that's happening, but also more recently by loss of focus maybe within the health area, but also beyond health, where there's a lot of compete and divergent efforts So what is it that we can do? I mentioned there's a couple of things that we are also trying to discuss with policymakers in this area. And one of those is really the expansion in many ways of the inequalities registry that has been mentioned so often already. In our view, it's lacking in ambition in many ways, I would say. There are many more areas that could be included. I think Till, in the discussion you've mentioned, like what really guides the implementation of the screening program, the functioning of the screening program, what really guides diagnostics, so like deployment. The same goes actually for the treatments, and we all know that there are those variances. We know that they are there somewhere, and the moment we look at them, we also understand that they're there, but there really is a lack of a coherent data and tracking over time. We can look into specific KPIs to try and understand, okay, where is it that we make progress, where do we not make progress, and what is the link between the data and then one or another screening program, treatment rate, or other areas. So that's one big element. What we've discussed a little bit over the past is if we could probably make use of tools that have been developed in the EU acquis more in the financial area. And the question there that came up was, would it not probably make sense to have a European health included in the European semester process? And maybe even to start, or ideally to start with cancer actually, as a pilot and model, as this would probably exactly allow to bridge some of the gaps that we've discussed before in implementation between the local and the national level and the European level, a more structured dialogue between the European Commission but also other European actors for some of the smarter funding of some initiatives. Measurement and ongoing evaluation of those cancer care indicators would be absolutely crucial. And I think the idea really would there be that this ongoing implementation and evaluation would support more political accountability. And for then smarter spending, something that's I guess we already need. So sufficient data to inform decision makers, and we will try to nudge them also to use the data to take the decisions and not just like have the data collected but also integrated. Better align EU and national initiatives around this data, and maybe, as mentioned, the European semester as a pilot process or governance process that would work in that area.
We're going through it very on time. Exactly. 3 o'clock. So we have questions.
Tomasz Tokosa, Medical University of Warsaw. Tilman, so I understood that you are from Merck Sharp and Doom, right? Because it's our comment, not a question. I would insist, you started that industry is not a partner. No, you are a partner. If you are not, you should be. We have a Harmony program, EU funded in hemato-oncology, where we have like an excellent example of the collaboration between industry and academia. So please, we think you are a partner, and if not, you should be. Okay, we really need you. Okay, thank you very much.
Thank you and appreciate it, and I agree. It was a little bit of a snarky comment. It was what Tilly mentioned before. It was a little bit with a smiley face attention.
I think Tim was saying that joint actions are publicly based actions. That there's support of coordination between different public health and
not by the exclusion of the consortium. Let me remind you. It's a policy-led project. So the politicians decide who is in, who is out. Research projects on Horizon, that's a different story. There are SMEs, there is industry, and so on. So this is very important to stress. It's frustrating sometimes that private entities also cannot be involved, but this is a political decision, political choice, let's say.
I have a question about access to data, because I'm representing a hospital and it's not easy to release data, especially its rules. It is not possible at all, rather in a federation or at least some kind of reports. So how you collaborate with other hospitals, institutions in terms of data access as a representative of industry?
I don't think there's a one answer to rule it all, to be honest, and I think it's also a fair point that we could, should, must be a bit better oftentimes in cooperating. I think the big challenge oftentimes is that it's a little bit unclear the usage of the data in the long run in some ways, or like what will happen, and then sometimes the linkage of it to say reimbursement and access schemes later on. I think that's where the big challenge lies. But I do think there is an increasing, not just recognition, but also openness to be to collaborate on individual specific projects, but also actually towards then pricing and reimbursement on risk sharing and other arrangements that like to bring this in. I do think though it's also an area, someone said hopefully this is not recorded, I think it's fine, it's recorded, but I think it's also an area where industry needs to be sort of like nudged to a certain extent, but also understood sort of like what the concerns of industry are when it comes to both data sharing, but also of sort of like receiving access to some of the data that we get, of course, for our own sort of like reimbursement.
Any other questions? Okay, now we will have a break for 24 minutes for about 3:30. And the second session is about public-private collaboration. So possibly fits into the discussion that we had now. Thank you to all the speakers and see you shortly.
No zobaczymy, nie wiem czy nie musi być będzie pięknie wyglądało.
Wydaje mi się, że odrębne też może mieć swoje plusy, tak? Oni tam z tym RCMC i CWBK to idą w jakieś takie kropki i coś tak kształt kropek, na świecie jest no tego też nawiązuje, że wychodzi z jakiejś kropeczki i jest taka strzelnika, że z czym mi się to kojarzy. Dobra, jest mój telefon, można zadzwonić, także dzięki za ten wstępniak i może jeszcze się uda go po prostu podrasować, żeby to by się złożyło w jakiś taki kształcik. Niczym podobny. Bardzo dziękuję. I do usłyszenia. No, dzięki. No, na razie, no, wzajemnie dzięki. Ja już wiem, że już jest mało czasu, ale jak się uda reportaż, to jeszcze dzień już można pracować nad nim. Ja też, that's a recording. So here's our presentation, a też już jakiś plakat poszło.
So can you go through this one here? So click on that, then this one will go on. Dzięki serdecznie. the last speakers.
Dzień dobry, Agnieszka Janowska z tej strony. Dzień dobry Panie Wojtku. Dzwonię jeszcze z naszej auli tutaj dużej, nie wiem czy Pan jeszcze w pracy zostałam. Aha, już nie. A czy ktoś jeszcze jest może od Państwa? Niekoniecznie. Dobrze, bo testujemy to puszczenie nagrania wykładu i podłączyliśmy kabel do komputera i faktycznie dźwięk jest, ale jest ledwo słyszalny, czyli jest tak minimalnie słyszalny. Się zastanawiam, czy gdzieś jest sterowanie do głośników w auli. Nie, mam wrażenie, jeszcze teraz przebiję, że z głośników na górze słyszę, ale no jest na maksa. Jest na maksa. Bo gdzieś nie wiem, zastanawiam się, czy jest sterowanie jeszcze do głośników tych na górze. Ale pewnie nie. No też tak bym zakładała. Coś tak cicho ktoś. Nie, bo jeżeli jest wyłączony w samym laptopie, jak jest włączony, chyba że po prostu z laptopa puścimy i nie wiem, czy sobie to zadziała, jak mikrofon podłożę do laptopa zwykły. Dobra, to jak Pana nie ma, to i tak już nie będę Pana kłopować, bo to ewentualnie po prostu się przyjść. I może musimy dopiąć go. Tak, tak.
Gratulacje.
It's not working, it doesn't work for this one either.
Are you sure it's this one or you think possible this one? You have heard it, this one. You check it connected here. Let's go to Wednesday.
You tried all of these. You tried all the different ones, try all of them, because
It's not open.
Can be very, very loud.
Development of clinical research personnel and also with more specialized equipment. However, what is important, Poland started the non-commercial research.
Okay, now we need there's an excellent idea. There's another.
does the video actually work?
The pilot, it's been a very good experience in the sense that it's an incredibly important thing for patients to have access to it because of what it does in terms of our doctor.
Okay, so now
Thank you. So
Yes, we are okay. This is just for the video.
The pilot, it's been a very good experience in the sense that
those patients who have had post-DMA, particularly for a targetable treatment, they're just ecstatic.
Bardzo w skrócie, ja mam wizję popularną.
The pilot, it's been a very good the
I saw a little bit yesterday already. I went like along the river, and then went to small studio. So it was really nice.
back, for those that are arrived back, and for those that will come. We wait for you, and those on the phone. Hope you're having a good call. So this title of this session is focusing on public-private sector collaboration and how can we improve this, or what is public sector-private collaboration, or what is collaboration in the first instance, or what is public-public sector collaboration, and what are the issues that we can do to improve this. So we have 5 speakers in this session, and although there are 6 on this slide, one unfortunately couldn't be here, that's why I don't have a problem counting. And so we have, my eyesight is not so good. So we have a first speaker, which I will move swiftly on to, is Philip Griffin, who's the head of Discovery Research at Germany. So I will give him the floor. He introduce himself better than I can.
Hey, hi everybody. So I'm Philip Griffin from the Fraunhofer Institute of Translational Medicine and Pharmacology, which is based in Hamburg in Germany. And I think maybe I'm here to talk about what is the archetypal public-private partnership, and that's the Innovative Health Initiative, which is followed on from the Innovative Medicines Initiative. And the project that I want to sort of draw your attention to is IDERA, which is a project that I coordinate along with my colleague Christian Lundijk from Johnson & Johnson. And we had the honour to be the first IHI project of the new IHI regime. So we were the first one to get our, in round 1, and the first one to get our consortia agreement signed. It was a struggle, but we got there. But what's IDERA about? And really it's about trying to create platforms that will allow us to integrate heterogeneous health-related data sets with the ambition that what we learn from the process of analyzing those complex data sets and applying machine learning and artificial intelligence algorithms to them and solving the problems around access and connectivity and data governance, sharing the use of federated machine and the federated processes to try to preserve privacy. They will allow us then to, other members of the team, to be able to come up with some policy recommendations and consensus about the most efficient use of these data, especially real-world evidence and real-world data, and for the purposes of regulatory and HTA decision-making. So we're firmly in the secondary use of data camp when it comes to the reasons why we're accessing the data, but we also firmly believe that you can create all the platforms that you like and set up all the algorithms that you think might be useful and give you amazing results and fantastic insights. But if regulatory authorities are not in a position to accept the finding of those algorithms, especially when it comes to decision making on reimbursement, for instance, and decision making on accepting a new medicine, then it's sort of all for nothing, as it were, in the secondary use of data space. So our mission is to establish those infrastructure elements and then see whether we can, through the use of them, we can demonstrate the utility, the approaches that we've developed. So every project has objectives. We are 1 year in, so of a 5-year project. So we're still quite early on. We're still quite in the nascent stage. But as we mentioned previously before, our ambitions are focused around a federated data infrastructure. We're hoping that will eliminate some, but not all, of the problems associated with achieving access to data sets in order to develop these analysis. We have a suite of algorithms and a special algorithm development team where we want to be able to apply them to the data sets in this federated setting. Our use case is an extremely important one. It is in lung cancer, and those algorithms are focused upon detection, diagnosis, risk prediction, and also prognosis. And we also have a small clinical trial which is included within the project. We do have some digital applications running on smartphones that will allow individuals to monitor their post-discharge health status. We're talking about complex heterogeneous health data sets, but we do need to sort of draw the line somewhere. We don't have the resources to be able to do large amounts of data curation, So we're very much relying upon the OMOP common data model when it comes to the electronic health records that we're seeking to gain access to. And many of the organisations that we've engaged with, both within our consortium, it's a large consortium with 33 partners, 6 industrial partners, but we have half a dozen of those partners are clinical organisations who will be providing access to data, but they will be getting their data into the OMOP form and performing the curation on their side. And also with DICOM image formats when it comes to our image-based data sets. We're trying to do this in a fair way, and we're also very much interested in data quality as well. So we're working with experts on data fairness and also data quality to try and see how both of those factors can impact the opportunities both for reuse of data, but also the quality of the analysis that we're able to perform when it comes to the data quality side. We do have a group specifically working on development of apps to allow for dynamic consent for secondary, so patients directly allowing for reuse of their data, and that's something that's very challenging, but we want to try and do that within the framework as well. Then finally, as I hinted at the beginning, it's all for nothing if regulatory authorities are not prepared to accept these findings, and if you can have the molecule accepted for clinical use, but if there's the health technology assessment organisations again are not prepared to accept what the added benefit is as demonstrated through the application of real world evidence of data, if they aren't able to do that. So we want to be able to provide policy recommendations around the use of these methodologies as well. So we have a model which is sort of based on the data space concept. So within Fraunhofer, and we're very much organised, we're very much interested in data spaces, and not just on the health data space side, but also in logistics and energy and automotive, etc. So the basic principles that we're putting forward, we want to see interconnectivity between different scientific domains. We're looking at this governance piece in a great deal of detail. We don't benefit from having access to standardized agreements that will allow for data access from between data holders and data users and infrastructure providers and secure processing environment providers, trusted research environment providers, which is sort of what we are, whilst the EHDS is being developed. We are sort of pitching ourselves into that position. We're creating a technical infrastructure that's built upon pre-existing components. We have Elixir as a member of our consortia, and we have the Fraunhofer again as a member of our consortia, which is well embedded within the data space community, and they're providing the key infrastructural components where we're not reinventing many things, we're sort of bringing pre-existing elements together. And finally, we've got healthcare solutions, so those are apps, algorithms, analysis tools that will be available from within our consortia, but external organizations will be able to gain access to data sets through the IDERA platform in the long term, and that's part of our overall sustainability. As mentioned before, we've spent the first year developing our architecture concept, so we now have a finalized concept. And if you look over the next few weeks, you'll see the draft of that. It's coming out as the deliverable 1.1 from the project. I encourage you to take a look at it. You can see that many of the elements are already picked out from what's already available. So we're using the life science login interface for user authentication and verification. We're using GA4GH workflows for task execution, etc. The passport system that they have as well. We're trying to make our data catalogs interoperable with those of other major EU projects, and we've published a couple of papers. And recently we're talking about our collaborations with projects like EUKIM and others, and iHealth and others who work in this space. So we do have an architecture which separates all of the processing which is happening in the computation center, computation node, with where the data is being held within the data providers and within those other organizations. So we got asked to look at this strengths, weaknesses, opportunities, and threats. So I tried to paste our standard PowerPoint slides into there. But I would say that one of our strengths, and sometimes it's a weakness because you can get a bit of groupthink coming in as well. But one of our strengths is that many of our existing partners are part of a lot of complementary efforts as well. So if we look at the Eden Consortia, for instance, those guys are really looking closely at how to improve the standardization of data sets within clinical organizations, so many of our partners are part of that. Also Optima, working closely on cancer-related data sets, EU Pearl, the Health Outcomes Observatory, the FAIR Plus project, so when it comes to developing methods for assessing the fairness of clinical data, that's where I've come from, the Gaia X and the data spaces environment, and we're sort of part of that. So I think we have a sort of a well-connected group of partners, both industrial and academic. And what are the weaknesses? Like everybody else, it's going to be about data access. So we're trying to do things slightly differently. Our current joint controllers agreement that we've got that will be facilitating data access is only 10 pages long. I think it's the shortest one that anybody's ever seen. And what we're doing, we've come up with a completely new approach to data access, and we're trying to include all the means and the purposes of why we're going to be doing, what we're going to be doing, what measures are going to be in place to ensure that data is worked with securely, what the technical considerations are. All of those are going to be included in the data management plan and the data protection impact assessment documents, and those will be supporting the entire process. So if activities happen and they're not in the data management plan, then they won't happen. So everything that we're doing in terms of data management will be noted in the data management plan. And that is not the usual situation. Usually data management plans are produced at month 6, and then they're looked at once again in month 60 of a project. We are using our data management plan in the way that the GDPR regulations envisage that it should be, to really try and map, understand, and know all of the data management activities that we're going to be involved with. And those technical elements are captured in the data management plans. They don't have to be captured in the legal agreement. So the legal agreement is only 10 pages long. So let's see how that goes. But that data access process will be relevant to both internal and external data sets. What are the opportunities? I think there's a lot going on, as we can see in today's discussions, are linking through to the European Cancer Plan, to what's happening in the European Health Databases, etc. There's a huge amount of interest in what we're doing, and we'll be very happy to sort of work with all of these other communities and make sure that we can integrate how the European Health Data Space development and what the provisos on how to work with data to make sure that they integrate into what we deliver as a consortium. When it comes to threats, by the same token, the EHDS will be developing and changing. It may well be the way it's being implemented might be changing, it might be different and diverse within different countries. We are a pan-European project. We have to be able to make sure that we can account for that. So we're saying it's a threat, but it's an opportunity as well. It's one of those complex situations. I think we got also asked to talk about sustainability. So I'm going to hop a little bit here to the EOS Live project that I was also involved with. And we had a publication that you can find in the EMBO Journal, where we looked at the EOS Live project. Was the work of a large consortia of all of the European life science infrastructure. So ourselves, EATRIS, Eurobioimaging, EU Open Screen, Armenia, everybody. So all of those folk got into a very large project with the ambition to be able to deploy large-scale data resources to the cloud and make them available for reuse, improve the degree of interoperability, improve the level of fairness. We were very interested in trying to see how we can make those resources sustainable. So you'll see more in this publication. I'd encourage you to look at it. This is not about a business plan. It's about how do I get the resources that I've generated to be actually worth making sustainable. That's the concept. What is it? What do we need to be able to do? So we looked at different definitions of sustainability at the organizational level, technical level, and things like in terms of having adequate metadata to be able to represent all of your experimental data in a reasonable way, the financial aspects of it, the reuse. There's no point in making something sustainable if nobody's going to use it. So it's sustained through reuse, and that's extremely important in engaging with users and making sure that your resource doesn't go stale and the previous generation has to remain state of the art. And also through training as well. You have to, the people who are going to use it have to know how to use it. So you have to have that training point as well. So we came up with an analysis of the challenges around sustainability, but also a set of tools that will allow us to try and improve and establish a sustainable resource. And we came up with a framework for sustainability around being recognized, practical, ready, unifying and clear. So I won't go into details now, but I would encourage you to have a look at this paper and see whether that might be relevant for analysing the sustainability of your data infrastructure and if there's anything to learn from that. Because this was a work of a huge consortium over a significant amount of time. And so finally, just the funding acknowledgements, and I'd be happy to answer any questions.
Any questions?
Thank you very much for the very interesting presentation. I have a couple of questions, if that's okay. One, you mentioned that you're dealing with data sharing using a joint controller agreement, which is very short, and you're planning to have the continuous update of the data management plan, which I think is a very good approach during the project. But what would happen? Well, my first question is, how are the DPOs, the data holders, receiving this approach, if you already have some feedback? And second, would this approach work after the end of the project lifetime, or are you foreseeing some different approach?
So I think that's a very good point. On that first one, Fraunhofer is leading this, and I've never, in my experience, I've never seen a team of lawyers actually being so excited. I think we have to remember that lawyers get bored with people throwing requests up and saying, "Where's my data? You promised me this agreement," and they get frustrated and angry having to wait 2 years, 3 years, 4 years in order to come up with a data access agreement. So actually, the teams of lawyers that we're saying can see the value in this process, because what it does is it means that the technical aspects are captured in the DMP, and all they have to do is to sort of talk very, very broadly about legal terms about who will be who will be working with the data and what the respective responsibilities are. So we're actually getting very good feedback on this, and Fraunhofer has now put this into 5 different projects now, and with a variety of different partners, and I think it's looking pretty good. We're preparing a publication around it. We want to share these templates so that people can use and reuse them themselves, because lawyers are sick as well. They're as sick as the people who want to use the data. After the project, so one of the underpinning examples of one of the principles of this agreement is that we are also bound by a common purpose, being IDERA partners, and we have to come up with a transition into another organization whereby that organization takes on the roles and responsibilities that the consortia took on in general. And you might imagine that a very large organization like Fraunhofer or Elixir might be able to actually operate and run one of these secure, these trusted research environments which are envisaged, or secure processing environments which are envisaged by HDS. So I think we can look at realistic models that would allow us to be able to sort of continue with that same legal framework.
That was great. Thank you very much. Thank you for following the agenda. Our next exciting speaker is all the way from Greece. I don't know where in Greece.
Currently Athens.
Currently Athens. Someplace. Please, go to.
Thank you. Thank you very much for the invitation and the opportunity to discuss here. I guess I was invited in a dual role as a representative of a company. I work for a large company, so private sector, and this section is about private-public collaboration, but also as the coordinator of Incisive, a large project on data sharing and AI development in support of cancer care, where a lot of public-private collaboration was ongoing. In this presentation, I will discuss a little bit about the best practices that came out from the project that I was coordinating, but also another 5 projects, so 6 projects with very similar goals, plus one that I will discuss a bit more in detail in the next slides. So first of all, what is the AI for Health Imaging Network? The AI for Health Imaging Network is a collaborative network of more than 100 institutions representing many different stakeholders coming from both public and private sector and representing from patients to healthcare professionals. Representing also more than 20 different countries, European countries, and all these 6 projects have as a common goal the creation of big health data repositories, especially cancer image repositories and accompanying clinical data, and using this data to train and validate AI algorithms, AI services in support of cancer care, especially related to the diagnosis and treatment of cancer. To give an indication of the scale of contribution of the projects, I will make reference to the final incisive results, since I'm a bit more familiar, obviously, with my project. So our project finished in the end of March of this year, and by the end of the project, we delivered more than 4 million cancer images, plus accompanying clinical data for each of these images from more than 10,000 patients in one hybrid data repository, meaning that it integrates data from 9 different data providers, actually more than 9, because each of our data providers was collecting data from 2 or 3 hospitals. And all this data is stored in a hybrid way, meaning in federated nodes, local nodes located in 5 different locations, 5 different hospitals who are part of our consortium, plus the central node in case that the data holder did not wish to set up a local node but wanted to share the data anyway. And we used this to create more than 38 AI models, many of these integrated into AI services in support of cancer diagnosis and cancer treatment. So multiply this by 6 and you get a very high-scale contribution of data and supporting tools for decision support of healthcare professionals. Of course, all this huge effort doesn't come without challenges. And these challenges in data sharing projects like those that we are working on are quite common for all of us. There are, of course, technical challenges ranging from technical interoperability, lack of technical interoperability because of the heterogeneity of the IT systems of the different data holders, but also motivational challenges because data holders lack incentives to share the data, and this is something that we need to admit if we want to overcome this challenge. Of course, economic and political challenges, and what I believe is very well known to all of us, legal and ethical challenges. So each of the projects, each of the AI for Health Imaging projects has come up with a number of successful solutions for addressing many of these challenges. Also, many lessons learned from things that didn't work as we had expected them to. However, despite the successes that each of the projects had, and also the very early initiation of the collaboration among the projects, the heterogeneity is still there. And it's heterogeneity that is multi-perspective. It relates to the IT infrastructures that each of us is using, the approach of centralized data storage versus federated data storage. Some of us are using federated, others are using centralized. There are different data models, there's still a lot of things to do to have this homogeneity of the data sharing landscape. So to understand a bit more what each of the projects did best and what could be improved, in Incisive we decided to take up a survey of all projects, involve participants from representing all the stakeholders from the 6 projects, and understand a bit more what worked and what didn't work, and how we could further facilitate data sharing. We interviewed all the coordinators of the AI for Health Imaging projects, as well as task leaders, work package leaders, but also data holders and legal experts, so that we have a multi-dimensional perspective of the different best practices. One of the main themes that came up from almost all the participants to this survey was the need to speak the same language. And of course this is expected, because these projects are multidimensional, they involve many disciplines, and obviously each discipline is speaking their own language. There is a strong need to align the terminology, because in many cases we found out in our projects that we were discussing about one term, but each of us is giving a different meaning. So if we want to really be successful in data sharing and in these projects of this kind, we really need to support this alignment of terminology and deeper communication between the different disciplines. Very much related to the previous theme is also the alignment of needs across disciplines. For the same reasons of multidisciplinarity, of different perspectives according to discipline, the needs are different. So there is a strong need to understand what the needs of the medical experts are, what the needs of the technical experts are, the legal experts, and then be able to structure this into a workable and implementable plan. Another theme, another best practice that came up from many of the participants of the survey was the need for a legal partner, presence of a legal partner since the very early stages of planning such a data sharing project. What is interesting here is that the participants stressed the need not only for a legal partner, but a legal partner with practical solutions. And this is what makes the real difference here. There is a need for bringing solutions to how we will share data, not just research possible approaches. This is probably my favorite theme, be proactive and decisive, because there is never going to be a perfect approach in data sharing. There is never going to be a solution that resolves all the challenges in the best possible way for all the relevant stakeholders. This is just too idealistic. So we have to be proactive and we have to take decisions. Of course, we need to discuss what is the best possible approach, the optimum one. But once there is an indication of this, we need to decide to take the approach and start implementing it. And this was stressed by many of the participants to our survey. And of course, the need is also to use standards, to reuse existing tools, not try to reinvent the wheel every time. Clarity of rules and structure of work is another theme that emerged, again, due to the multidisciplinarity and the complexity of the legal and ethical landscape, the technical landscape. It hasn't been always clear to the stakeholders of the AI for Health Imaging projects what the rules are in each of these domains and how we could structure the different opinions into something that is implementable within a realistic time frame. So this is what they came up with, and I really like the last quote that comes from one of the legal experts that we interviewed, who said that we cannot have a uniform solution for data sharing, but we should at least try to have a harmonized solution that has no contradictions. So again, realistic plans, and it's all about taking decisions with specific approaches. Trying to extrapolate the findings from the project level to the EU level, I would say that there is strong value in multidisciplinarity in these EU-funded projects. I think we are all very well aware of it, but there is a need for the stakeholders, for the member states and the European Commission to further support the deeper communication of the different disciplines, not only at the project level, but maybe by taking up actions that work across projects for establishing, for example, common terminology, helping to align the needs and helping to share best practices instead of reinventing the wheel every time we start a project. The need to harmonize implementation of legislation and eliminate contradictions. I think this is quite clear to all of us who have been involved in data sharing activities, as well as the need to take timely decisions and practical guidance to implement the European health data space. There is never going to be a perfect approach for implementing the EHDS, so the policymakers should take decisions and should provide practical guidance on what could work towards the implementation. Reuse of existing standards, tools, requirements. Again, this is an area where we could have some more support in making these available and shareable to be reused. And a lot more to be done for motivating data holders to share data. I will finish the presentation with a few thoughts on sustainability and a positive message. But first of all, I'd like to mention that motivation goes hand in hand with sustainability. Why? I will bring the example of the Incisive project, the Incisive data holders. The project finished in March, and our goal was to make this data shareable and accessible even after the end of the project. And of course, we needed the consent, the agreement of all the data holders. And that was a big question mark for me as coordinator. Why would they want to continue making their data shareable? I was positively surprised to find out that all of them agreed to make the data accessible even after the end, because it was already clear to them that Incisive repository would be sustainable. So this is really a key factor to convincing data holders to keep making their data accessible. And Incisive will be sustainable thanks to the EU KIME initiative. This is a project funded by the Digital Europe program, which is meant to integrate and make interoperable all the data repositories created by all the 6 projects that I mentioned before, plus many more data infrastructures and many more individual hospitals, data holders who wish to share their data. Integrative efforts are also very important if we want to have sustainability. It's not just about our own little project, but it's about making things interoperable and putting the pieces together. And this is an area that the European Commission and the member states should support further. They are already doing quite a lot for it. There is also a need for time. There are many best practices, many good approaches for sustainability in each of the individual projects on data sharing. However, these best practices do need to pass into reality and need time to do this, to mature and be turned into practical things that will work in real life. I will finish the presentation here. Thank you very much for your attention.
Thank you for a great presentation. Any questions? Philip, do you have any comments?
Yeah, I mean, it's not a criticism, but can we really measure success by sort of rolling project A into project B, project C, and a sort of endless series of EU projects? well, what's real success about sustainability? And that's something I've struggled with, because the model is, let's just get a bit more money and do this again slightly differently. Sorry to be cynical, but it's that's what I've seen so many times. How do we break that cycle?
You're not cynical at all. Thank you very much for the question. I had very limited time to bring all the information to the audience. So I didn't have enough time. I should have probably put this here. The EUCAM project is not going to be continued with another EU project. It's not the goal. We have already started creating the discussions for becoming a European digital infrastructure, EDIC, which I don't know if the audience knows, but it's going to be a self-sustainable entity, a legal entity, that will receive support from the member states, possibly the European Commission, and as a legal entity, it will be possible to join EU-funded projects and other activities that will co-fund part of the effort. But the idea is that this will become an EDIC, so a sustainable, a self-sustainable infrastructure.
Thank you. So if I can follow up on this, so being an ERIC, you work like what, the federated, distributed centers, just with metadata at the core? Do you have already?
No, in EUCAM we are building a federated infrastructure, not only storing metadata. Of course, we are storing metadata about the available data sets so that it's possible to search for it and make it findable. But we are actually storing data. It's a federated hybrid infrastructure.
So the data is leaving the countries to go to the central nodes?
This depends on the wish of the data holders. A federated infrastructure means that we hold a central node, as we did in Incisive. There's a central node for those data holders who agree and don't want to set their own node set up, but they agree to transferring the data to the central node. But for those data holders who wish to set up a local node, it will be possible to make this node interoperable, technically and operationally, and keep the data where it is, and be accessible still if the necessary legal and ethical agreements are in place.
Thank you.
Great presentation and impressive experience. Thank you. I have one question, but in two parts. So the first, how have you collected the information about the outcome? For example, if in imaging, how did you measure if it was successful to learn the algorithm, and also if you have also combined this imaging data with clinical data, maybe.
I'm not sure if I understand the first part of the question. For the second, yes, we have imaging data accompanied by clinical data for each patient. Based on the type of cancer, we define which are the relevant clinical data, and we collected this. The clinical partners did. I'm not sure I caught the first part of the question.
Yeah, in order to train the algorithm, you need to understand what was at the beginning and what was the result. So, for example, if there was a proper identification of a cancer with the image, so probably the clinical data could be used for that or some other means.
We used, from the data that we collected, part of it was used for training the AI algorithms, and part of it was used for validating the results, the outputs of the AI algorithms. So there was a process of validation for each of the AI models. Some of them were more successful depending on the amount of data it was trained on, also on some other factors. But if that's the question, yes, we have validation results for each of these algorithms. And we also had several usability evaluations with clinical experts who actually used the AI services and gave us their feedback about how good the performance is, how usable it is, if it's easy to integrate it in their existing workflow, and many other very useful feedbacks. I have to say we were not successful in everything. There's still a lot to do in terms of using these AI tools. But for some of them that are more mature, I think we are in a very good path to bringing them to clinical practice.
This is not a question also because of these outcomes, especially in cancer, when we use RESIS or when we leave RESIS, this outcome is mandatory to understand that, whether we should share that in this case, in terms of monitoring, the response, for example, would be the stable disease program, the disease progression. So this other also are to monitoring the responses, or just
in one of the projects, in the Incisive project that I was coordinating, we focused on diagnosis mainly, diagnosis of cancer and prognosis of survival for the next 3 years. However, in one of the other AI for health imaging projects that I'm also involved in, the Radioval, we are involved in predicting the outcome of the treatment. So that's this is still work in progress, though it hasn't been validated yet. Yes, the project is on breast cancer and evaluating the outcome of neoadjuvant therapy, whether neoadjuvant therapy will work for a specific breast cancer patient or not. This is what the decision support we're trying to build is.
Okay, thank you so much.
Our next very exciting speaker, very exciting, is Thomas Meyer.
Thanks. Very good. So, witam, jestem zaszczycony, że zostałem zaproszony na to wieczornie. So that's going to be my only word in Polish, otherwise my mother will start to be very ashamed of me. So, I'm Tom. So, thank you for, I'm Tom Zimayo. That's a big whisk. I'm head of diagnostic in oncology at AZ. And I'm very honored today to be invited to speak about inequality of care and with the specific lens of diagnostic. Okay, good. So when we look at the reported tested rate in metastatic lung and colorectal cancer for the recommended biomarkers, we see there is a roughly half of the patient not receiving the full testing workup. And this leads ultimately to a great inequity in terms of access to the best potential care. And so naturally, when we dive into the reason for this very suboptimal testing rate, we stumble upon many factors like biomarker validation, issue in lab structure and capacity to test, lack of awareness of actionable biomarker, and the fact that we've got a separate HTA, so health technology assessment, for diagnostic and for the corresponding drug. And we also got a lack of funding process, and so we've got also a lack of suboptimal funding for testing. And I think that if we focus on this last barrier, the funding one, which is certainly the one playing the biggest role and the most complicated to address, we could see that there is a lot of discrepancy between European countries in terms of how diagnostic testing is funded. So from fixed tariff to gene by gene funding to no funding at all, actually, with sometimes pharma coping with this absence and forwarding to some extent. And in addition to that, even within a given country, we could have stark differences in terms of access to biomarker testing due to provincial organization of healthcare, like, for example, in Canada or in Italy, because whether while you're sitting in the country, you may not have access to the same type of diagnostic. So I've got We'll switch back to full screen mode after. So this discrepancy between countries has been captured in the following illustration by Nicola Normanno and team. Those discrepancies span across multiple dimensions, like access to single gene testing, access to multiple gene testing, but also across testing quality. And you've got there a similar picture from Arno Bale, from Gustave Roussy, in terms of access to testing, but what I would like to focus is on the graph on the right-hand side, showing that the more advanced testing technology, like liquid biopsy or large panel or RNA-seq, are at the highest likelihood for those technology to be only offered in private setting, increasing mechanically the inequity of access. So I cover the inequity of care between European countries, but there are also a strong inequity of care within countries. And sadly, the literature is a little bit less abundant regarding this topic. But what you could see in the adjacent field of early cancer screening is there is a 40-point difference in terms of participation to cancer early screening program between the lowest and highest level of education within the same country, according to the European Cancer Inequality Registry. And go back to the full presentation. So for the second part of this presentation, I would like to do a deep dive in a case study on liquid biopsy. So we know that tissue testing could be challenging due to lack of material, quality issue, but also potentially due to just lack of access to material due to patients who fail to be biopsied. And this is an issue which is particularly acute in lung cancer. And so the consequence, if we are summing up all of these reasons not to get a proper tissue testing, we end up with up to 40% of non-small cell lung cancer patients who could have a suboptimal tissue-based genotyping. And so liquid biopsy could be a good solution to salvage those patients with a first tissue test. As illustrated in this infographic, the usage of both tissue and liquid biopsy could help to identify up to 15% additional patients with actionable mutation. So a very good potential to make things better. But sadly, the adoption of liquid biopsy in Europe is a little bit lagging behind when compared to the US, and is quite often limited to very expert academic hospital or comprehensive cancer center, like the one we are sitting in today. And when discussing with HCP about the underlying reason for not adopting liquid biopsies, there are two elements that are cited very often. The first one is that there is a lack of technical know-how, a lack of confidence to adopt this new technology on site. And the second reason cited is that there is some doubt about the transferability of the results in literature in terms of additional patients identified in terms of real-world setting. So, as a consequence, AZ is acting at its own level, small level compared to a safe level, but to diminish this inequality of access to liquid biopsy by setting up a Center of Excellence in Liquid Biopsy initiative. So there is two parts in this program. The first part is aiming at technical training for the testing labs to make sure that a lab willing to implement liquid biopsy feels confident in terms of its ability to do so. And the second part of the project is to generate local real-world evidence and in with the MDT, showcasing in the labs which have been trained the impact of liquid biopsy in terms of additional identified patients. And so far, we set up two of these centers of excellence. Those centers of excellence are set up in high-profile academic labs. The two we got are in France in Nice and in Italy in Naples. And we've got roughly 10 labs which have been trained in liquid biopsy right now, and we've entered into the evidence generation study phase. We've got a plan to expand this type of initiative to Spain and Germany this year, and maybe to other countries in the upcoming years. But again, this is our small contribution to diminish the inequity of care, which is in this case driven by differential access to testing for cancer patients. I do not have any slide about that, but I've been asked to provide my perception about the strengths, the opportunities, the weaknesses, and the threats around inequity of care. So I think that in terms of strength, there is a rising awareness of the issue of inequity of, in terms of cancer care for patients. So I think that knowing the enemy is already kind of a strength. In terms of weakness, I think, as a little bit as outlined in the previous slide, we are lacking the tool to measure the extent of this inequality within countries. And as there is no improvement without measurement, that is a sharp limitation in terms of what we could achieve and how to measure success. In terms of opportunity, I will relate to the upcoming Polish EU presidency starting in 2025. I think that inequity in terms of access to testing and care, cancer care in general, has been flagged as an issue to be resolved by the latest EU Beating Cancer Plan. So it's a strong priority, and I think that it helps to get the ball rolling. And in terms of funds, I could think that the access to budget for healthcare become an issue with competing priority like fight against climate change or industrialization and so on. And so really this access to specific funding of healthcare may be the biggest threat and maybe one of the big drivers of inequality in the future.
Any questions?
Thanks for providing the answers to the questions.
And for these masterclasses, was there good uptake in the masterclasses with interested professionals?
So yes, actually, we are more in position to refuse to participate than and try to select them. I think what has come a little bit as a surprise is that it's not only the pathologists who are interested from an intellectual standpoint, but really an MDT effort, so a multidisciplinary team effort, meaning that this is a joint interest for both the pathologists but also the oncologists to have this capability in-house, and as this is rather training technique from sensitivity standpoint, maybe we know a little bit more about that later. I think being reassured about the capacity to implement it in real life is super important.
So then you probably identify different capacities. So you have these training programs, and so when you go back to their cancer center, you don't have the resources to implement what you have. How can they do that?
So I think we are helping for the initial setup. We are helping to generate the data. And I think about this help, it's a 6-month help as a seed investment. Meaning we want to provide a proof of concept that yes, it's working in this setting. Yes, we find more patients. And once you got this level of conviction, then it's up to the system to take over, either on the own funding of the hospital, or maybe then it's up to the conflict expert to rise up the issue of funding for testing at the highest level nationally.
And looking at France and Italy, how is the system responding?
So I think we've got quite different situation in France. Actually, the system for testing and NGS testing was quite visionary. It has been set up very early on, almost 10 years ago, but with sadly a fixed amount of money. And as the number of use cases are exploding, the level of reimbursement per test is drying up. And currently, this is not a liquid versus tissue issue because this type of funding is available for both types of testing, but we are ending up in a situation where some oncologists are restricting themselves because they know that the reimbursement rate is not is a little bit suboptimal. So it's a little bit going down in France. In Italy, this is a little bit the other way around. I think we still got a strong difference between the northern part and southern part of the country, due partly to the regional healthcare system I mentioned earlier, meaning that some regions are topping off what the money which is available for testing. But nevertheless, we've seen an increase in terms of funding. So I think there are two parts in the issue. One is the amount of money, and two is how you funnel it to make sure to make the possibility.
Now you have Germany and Spain. Are you optimistic about this?
Quite. I think with very different type of challenges. In Spain, in Italy, it's a question to set up the capabilities. Just because so far testing in Spain is mostly paid for by the pharma industry, and this is quickly shifting. And as a consequence, there is a need to implement more local testing capacity. In Germany, I think the situation is quite different. I think the infrastructure in terms of testing in Germany is just top notch, but we've got to work on the willingness to implement new technologies, meaning that if I got to draw a parallel, there is less conviction from the oncologists about the benefit of liquid biopsy compared to what we could see in other markets. So it's more about education and conviction and less about the technical part. And that's really the interesting part of the project, that we are trying to cover both issues.
Thank you so much. Our next speaker is Ben Gannon, Guardian Health. Well, I will be first as well.
Thank you, Dennis, and Thomas, and the organisers and hosts. It's always a privilege to speak at your meetings, and I'm very honoured to be here today in Warsaw. Guardant is not a company which is currently involved, unfortunately, in any of the substantial EU funded projects, and I wish we could do more, but we're still a pretty small operation over here. But I am going to be talking about some of our collaborations with the public sector, and we have a very important foundational piece of our work, which we call our public-private partnership laboratory engagement, and I'm going to talk about that and how I think we're beginning to address some of the gaps that Thomas talked about in his presentation. So the first thing I wanted to just show you is some of the activities that Guardant is doing across the continuum of care, and we work in the screening and the early detection space, which is here on the left-hand side. We're involved in developing technologies to support recurrence monitoring in the area of minimal residual disease, and the other area is in the late stage in relation to treatment selection and optimization, particularly to answer the questions for oncologists and for patients around what is the right treatment for me and how I respond to the treatment. You see on the right-hand side three logos or three brands. One of them is Guardant 360, that's the flagship product of Guardant, which I'm not really going to talk about, other than that it is the basis for the technologies which have been developed in collaboration with the Royal Marsden Hospital in London and Vall d'Hebron, the VIO hospital lab in Barcelona, and they are now running effectively the same assays that we run in the US, which are called the VIO 360 and the Marsden 360. So they're running the same assays, which means effectively the very same performance, both in terms of the sensitivity, specificity, and importantly in terms of time. And I'll talk about a case study around what we're doing in England with that assay, which I think is quite an interesting success story, which could be taken to other countries in Europe. Before doing that, I just wanted to say a few words around Guardant's role in developing the evidence base. None of the work that we do in terms of the healthcare systems in Europe is without being able to demonstrate clinical utility, and ideally we demonstrate clinical utility in the local cohort of patients. And I think what's interesting is that in terms of our global spend on research and the studies that we have been supporting internationally, 30% of the activities that we do globally happens here in Europe. And I think it's, on the one hand, that's a fantastic testimony to the academic excellence and the clinical excellence in this region. On the other hand, I think it's also a bit of a shame that we're spending a lot of money here and treating and developing such fantastic evidence, which is then used by my colleagues in the US to support accelerated patient care in America. And we need to do something about that collectively. Let's touch on some of the points that Thomas talked about. Whilst liquid biopsies have fantastic potential, there have been a lot of question marks across the community, both here and in different countries internationally, around the performance of liquid biopsies. And it's absolutely critical because when you're working, particularly in a community setting, the sensitivity of a liquid biopsy of this technology needs to be very, very high to be able to detect those genomic alterations, which are sometimes in low sample quality, but more importantly, the DNA which is shredded into the blood is not often to be found, or is difficult to be found. And I think over 50% of the disease-causing or somatic alterations in the tumors, the solid tumors that we're working with, are only detectable to a certain level. I won't go into the detail here, but it means that the type of technology that we work with needs to have has to be highly sensitive to be able to detect a significant proportion of patients that you would otherwise be missing. And I think it's very important in terms of that capability in the lab. That's often one of the challenges that we have to support and work towards. So how is Guardant Health partnering with these institutions in London and in Barcelona, and hopefully in a few other institutions in Europe in the next few months? We're delivering an end-to-end automated standardized ctDNA workflow to partners in Europe. And if you look at the graph here, or the diagram here, you see three effective steps when we talk about end-to-end. So firstly, we build and support the institution in terms of how it deals with the sample when it comes into the lab. So how is that sample then, how is the chemistry around the sample to extract the plasma, to extract this DNA, how is it prepared for the sequencing? So there's some proprietary chemistry there, which we transfer that technology to the partner institution. Then you have the next generation sequencing. We're working with Illumina instruments, the NextSeq and the 6K and so forth. And on the right-hand side, you have the bioinformatics, the AI piece of the jigsaw puzzle, and that again is a proprietary piece of software and algorithms which support the institution on the annotation to develop a report, which then the physician of the oncology can use. I think it's quite interesting in the conversations that we have with institutions around Europe, is that we're removing a lot of the manual aspects of the workup of the sequencing, and the substantial part of the added value of this engagement is to support the reporting, the ease of the reporting, and the annotation for the institution. Having said that, and Tom talked about this, even though we've got ESMO recommendations which were published in 2022, so just almost 2 years ago now, we've heard and we know that there are very, very many barriers to adoption for NGS, both tissue and liquid in clinical practice across Europe. And I'll also give a case study in the area of liquid biopsy and show you what we're doing in this space in advanced lung cancer. And it's quite dramatic actually, because even though we have a number of therapies now, even in Europe, which are certainly approved and also reimbursed in many different countries, between 8 and 9 biomarkers and up to 12 biomarkers are now treatable with targetable alterations. Over 60% of patients are missing out on the opportunity from having access to these available therapies for many, many reasons across that referral pathway, across that chain of standard of care. And Thomas talked about a few of those. It relates to the referral process, what you do with the biopsy, how the biopsy and specimen is managed, all the way through to the testing performance and so forth. So I wanted to talk about an example. I've got a couple of slides left in this presentation with a video, which I hope will work here. We've been involved in a program now from the work with the Royal Marsden and with NHS England, and this has gone in 3 phases. We established a pilot program based on some of the early clinical data from some of the studies which were actually performed during the pandemic. So these were relatively small studies initially, which were demonstrating the clinical utility of liquid biopsy in a cohort of patients being managed and supported at the Royal Marsden. So a comprehensive cancer centre, a highly experienced and well-known centre in the UK and in Europe. But that led to engagement from the oncologists in that institution to work with NHS England to develop some funding for a pilot project to test 700 samples with liquid biopsy across the country, utilizing liquid biopsy. And you see here some of the results here on the left-hand side. Suffice to say, we were, with our test in that institution, finding between 20 and 30% more patients than the tissue biopsy or the tissue NGS pathway was finding. But most importantly, the turnaround time and getting patients onto treatment was being dramatically shortened. So the tissue pathway in England, there's not much published about this because there are some challenges around this, but effectively it's between 3 to 4 weeks to get a result for tissue NGS with a good timeline. With the liquid biopsy, we were getting a 9-day turnaround time on average from the sample being sent to the receipt of the report in the oncologist's hands. And those dramatic findings led the oncologist community to then engage with NHS England to expand that study. They then tested 2,000 patients, and interestingly, those 2,000 patients were then tested with the technology transfer that Garden managed with the Royal Marsden, so we were bringing that technology into London, into the local healthcare system. And from that work, the NHS England has now announced from April this year that they will test 10,000 image suspected or suspected lung cancer patients in the country over the next 12 months. So 10,000 patients is effectively half of the advanced lung cancer patients who are eligible for care in England. We think this is an interesting template to be taken to potentially to other countries. I'm going to see if this works, but I have a video which we took recently with the support of some of the partners in this project at the most recent thoracic oncology conference in London. Oh, it is. Sorry, here it is. There it is. Let's see if it works.
The pilot has been a very good experience in the sense that it's an incredibly important thing for patients to have access to it because of what it does in terms of our diagnostic pathway. We were getting really important information from a patient's perspective about the biology of their lung cancer.
For those patients who have had positive DNA, particularly for a targetable treatment, they're just ecstatic that they can start their treatment so much quicker than conventionally.
Comprehensive, gold standard molecular testing. What does that look like? It looks like tissue, next generation sequencing with liquid. And then when you have that complete profile, you've got, for example, you find no actionable mutations, I think you can have confidence that moving on with systemic therapy, which is what that patient is then going to end up having, is the correct decision.
Certainly if you had someone where we picked up a targetable mutation early, then that is going to save lives.
It's very, very simple. You must do it. It is absolutely transformational. If you are running a lung cancer service that doesn't have ctDNA, you are running a substandard service. It really is as simple as that. I would not send my relative to be treated with lung cancer to a centre that decided not to offer this. That would be, for me, be a barometer of poor care. It really is as simple as that.
This is my final slide. So in terms of the question around are these public-private partnerships already impacting healthcare, I think in terms of the programs that we're involved in, although we're not involved in every country in Europe as much as we would like to be, we're beginning to see demonstrable success and real impact on many more patients now than have historically been able to access this. And so I put some commentary around what is needed. I think it's around engagement and education in terms of the value of these technologies, conversations around how we can bring these workflows into and across European healthcare systems, and work together to generate the data to continue to prove the clinical utility.
Thomas.
Thanks for the presentation. I think expanding to Europe is a very smart strategy if you want to see usage versus some of your competitors which are staying in the US. So kudos on that. My question is about MRD assays that was not covered in your presentation. It's totally fine. But we know that there are two types of MRD assays, one which are quite generic and some which are not tailored to the patient, trying to capture the actual specific genomic installation that is otherwise, which are from only the patients, which leads to some tailoring of the assay. What are the of the two approaches? What are the ones you are currently exploring? And if it's the tailored one, what do you see as the challenges to implement in real life beside clinical trial? Because questions rooted from the big potential of this type of assays.
So in terms of there's tumor informed and tumor agnostic. So I'm assuming is that what you're referring to in terms of the approach? Okay. So ours is tumor agnostic, so it's not specific to the patient. It's a blood-based technology only, and in terms of what we're seeing, we are two of our largest studies to again prove the clinical utility are running in Europe. One of those is with centres in Italy, and one of those in the UK at this point in time. And our view, time will tell with the outcomes of those studies. So far things are looking quite promising, and I think it's a bit early to tell. But I would say the template for MRD in terms of the approach that we'll undertake will be very similar to what we've seen now with NHS England. So, and I would imagine it will be in one of the other European countries where we will engage with a healthcare system to develop a demonstration project and then take from there.
What should Europe do to support liquid biopsy? So it's invested a lot of money. We've heard of great projects like CanHeal, of course, speaking. So how can Europe speed up this? You're trying to provide the evidence. You're localizing the test now with different collaborations in different hospitals. How can Europe speed up the process? Is it a regulatory issue? Is it an evidential issue? Or is it a funding issue? Or is it a data issue?
It's probably a combination of all three of them, all four of them, all six of them. I think it's where do you create an incentive? And this is I'm talking here from a private market, a private company standpoint. Worked many years in the pharmaceutical industry where the data exclusivity and IP situation is very different. What I see in the diagnostic space is there are many fantastic ideas, but we never get to a point where there is scale because there are so many ideas, and so an idea comes, and so I think that's one area is where is there an ability or an opportunity to develop a set of incentives around in this space. And then the other piece is on the funding side of things, the reimbursement authorities don't have, they have staff, they have methodologies, but they're pretty much focused on drug reimbursement, which is fine, and other healthcare technologies. I guess there should be some demonstration projects in the area of how we evaluate technologies in advanced diagnostics that I think would be useful as well.
It's not so much a question, it's an answer to the question and your answer too, because Europe has already answered, in fact, because they opened a PCP to develop a liquid biopsy test, and we were in discussion with Guardant, but there is restrictions, of course, in the PCPs on whether you're obliged to do more than 50% of your research in Europe, and that was a problem. But I think one of the issues is, in fact, yes, we should have the evidence, and it would be nice that the evidence can be provided within Europe. That's something. And second thing is the price, because we set the price for that could make it sustainable, because there is a vivid interest to apply liquid biopsy in the future, and CanHeal is focusing basically on liquid biopsy. So we would be welcoming to have a discussion with Guardant and with the teams that we have to set up some demonstration testing on that.
Thank you. That's really good to hear. Now, just on the reason for running develop these public-private partnerships are, we know that for a healthcare system to send many thousands or tens of thousands of samples outside of the country, let alone to the United States, it's not going to happen. One piece, which we fully recognise. The second piece is the economics around these partnerships will work with the reimbursement levels that we expect collectively for diagnostics. And I would say for advanced diagnostics, I think this has to be a discussion there, but we're not talking here about reimbursement levels that you see in other parts of the world. So, and I think that's an important piece around how these partnerships work.
Thank you so much. Last speaker of the day will be approximately 10 minutes. And the title of his presentation is James.
Thank you. And thank you for the opportunity of speaking about a joint action in a session about collaboration between the private and the public. It probably is not very happy about this, but possibly in the future, once the networks will be established, there will be a lot of cooperation between the networks themselves and the private. You know that this joint action was foreseen in the Beating Cancer plan, with the objective of shaping, of building this network of expertise in order to exploit, by networking, cross-border sharing of knowledge, of expertise, of resources, to tackle transversal specific conditions which cancer physicians and cancer patients have to face daily. The joint action started in October 22. We coordinated in Italy and in Milan, and with the ambition of building, of creating these networks and setting them ready to start their work. And please focus with the last sentence, where they say, healthcare networking can be a privilege hallmark of the EU, having the potential to target health of its citizens in a highly coordinated fashion, again, cross-border. We're a group of 60 beneficiaries and 20 affiliated entities among 16 countries. I'll give you 3 seconds to check if your country is in. And this is the structure of the joint action. We have 4 work packages dedicated to the management of the joint action, 7 work packages, each dedicated to one network of expertise. We have I'm happy to see some work package leaders here. We have one or more network dedicated to complex and poor prognosis cancer, one on palliative care, survivorship, personalized prevention, omics, high-tech medical resources, and the last network on adolescent and young adult with cancer. We also propose to the European Commission 5 transversal task forces, meant as work patches again, which will focus on the integration between healthcare and research, integration between European Union networking and member states, between IT infrastructures and AI tools, and 2 task forces, one to study the European reference network model, which you know has faced some issues, especially as regards sustainability after they were created, and the other focusing on how to involve patients in this network of expertise. I will not go through the specific work which is being conducted in all the network expertise, because I will need 10 minutes per network, so 70 minutes, and then it's just ask me to stay the time. But any network had to, among the objectives of every network, we have to look for the scope of the network, to decide the activities, the potential partners, government, sustainability models, and so on, looking for indicators of efficacy and cost efficacy constraint. And of course, relation with not only the member state, but also other European and national initiatives, networks, joint actions, projects, and so on. In the end of the project, we also, the joint action, we will launch an expression of interest, a call to engage the partners, future partners of these networks. I am among those who follow the template, so I try to identify the strengths of our joint action, of this network of expertise, and indeed networking is the first one, because again, networking is the model the European Union decided to exploit interaction between the centralized governance in the member state, and which probably is the best way to tackle inequity and disparity, trying to find a common way in all the member states on how to go on. We have very focused activities which will focus straight to the existing gaps in all the conditions the networks will focus on. These conditions are really transversal among cancer care, and of course these networks will be very inclusive, although, what happened? I think I pressed the wrong button. Although inclusivity may be an issue, because it's very hard when deciding the endorsement criteria for the partners of the network expertise to find some criteria which are enough inclusive without being too much, because huge networks are, of course, unmanageable. I always say that with all this net, we will always need to be the fishermen and not the fishers, because else we will be, of course, dead. Possibly creating networks of networks may be the solution, like creating network of expertise which have few partners per country, and these partners may create national networks focusing on the very same topic. And this is something that, for instance, in the European Reference Network is happening. We are coordinating the National Red Cancer Network, which, and of course, are also involved in EURACAN, so it's already a network of networks. There's a certain risk of overlaps. We are trying to transform these overlaps into synergy, working very close with the stakeholders of the other project and joint action ongoing. And stakeholders are really the opportunity in this moment for this joint action, because we are interacting with very strong-willed stakeholders, which include not only the European Commission but also the member state, the Comprehensive Cancer Network, scientific society, and patients, and so on. And as regard threats, again, the risk of overlaps and sustainability, which is always a problem when talking about networks, especially if the networks are so heterogeneous in their governance, in their objectives, and also due to the fact that networks are not legal entities, and thus we have no idea on how to fund in Europe non-legal entities rather than research grants. And you know that the European Union, DG Sante and DG Research are different, so in any case you need to interact with both. So key action to be taken in order to help sustainability would be to evaluate and define the efficacy of the networks. Probably not all the networks need cost-effectiveness analysis, but anyhow, defining the cost of networking, there's definitely one, and obviously finding new solution finance non-legal entities, which could be probably transforming non-legal to legal entities. We will address all these issues in a new deliverable we plan for closing Jane, the joint action in next September. It will be a green paper, so with the objective to raise a discussion among these topics, which will be addressed to the European Union and to the upcoming new parliament. You know, we have elections next month, and we plan to present this document just at the final meeting of the joint action plan on the 24th, 25th of September. We already have the follow-up of this Jane, which will be easily called Jane 2, which will last 4 years, starting just immediately after the end of the first joint action. and will be focusing the implementation of the network, and so starting the activities we have planned in January. That's all. And for questions, thank you.
Any questions? Sorry.
Thank you for the presentation. I like Jane very much, being responsible for public cancer. So one question is about endorsement. Indeed, to endorse a site, institution, organization to be a part of a network is one. It's not easy, especially because we have different countries, we have different infrastructure, we have different players, and it's not a good idea to just to exclude someone because of the cutoff. However, on the other hand, what about the endorsement of the network by the policymakers?
Well, I mean, I agree with you as regards the endorsement criteria. For instance, it was saying this morning, volume is not enough, because if you have a small size country, you already have an issue. So there is excluding some countries. So we definitely have to find, and of course, the criteria depends on the type of network. For instance, in poor prognosis cancer, you may even use the volume, but the volume is not enough, as we said. For others, you definitely cannot use the volume. Probably we need to find transversal criteria and really exploiting the networks of network and the infrastructure rather than the institution in finding the partner of the network. Of course, the endorsement by policymaker really depends on the will of the member state to invest on networking. I think we have the European Union, the Commission is really focusing on networking. This is already an indication for member states to really do the same. But I think we will need, if the support is not coming from the member state, we will need to demonstrate them that things can be really changed by sharing cross-border resources with other member states. And of course, it is not clear if the support should be also financial or not, because this is definitely an issue for the member states as well.
So you highlighted about fishermen and banks, which is the key aspect. But in network, with the word work is the key aspect.
Yeah, because in Italian the name is pretty the same. It's rete and rete, so
how can you assess the working aspect? Because there's a lot of investment from the European Union in joint actions in these networks to socialize and to create a momentum between willingness for cooperation. But the key issue is the working aspect to ensure sustainability. So how can we identify which of these networkings are working, and then to have a reward system, maybe through the answer in between?
yeah, I mean, we will try in the review paper to give some suggestions. Of course, you use the right words, sharing, cooperation. I mean, networking in the past was probably more meant like centralization. Centralization is a type of networking which is definitely not effective, but in some situation, networking is really sharing resources and exploiting them to improve an outcome. I understand measuring this outcome can be hard, especially in some conditions, but I really also understand there's not really necessity of demonstrating networking is improving outcome, because results are obviously better than the past. For instance, I don't know, one of the activities of the network on AYA will be promoting initiatives to focus on the social, economical consequences of adolescents and young adults with cancer. We lack in most of member states any specific setting in this sense. So getting to results will already be the demonstration of efficacy of these networks. I I mean, if we have gaps and we fill these gaps, we do really need to demonstrate the.
Thank you so much. Quite good today. Mark will be proud. So now we have some concluding remarks. Ivana, do you have any concluding remarks for today?
I would like to put my back up to the end.
Okay, so that was short. Mark will do these tomorrow, I guess, as well. And my morning exam tomorrow morning, we will start at bright and early at 9 o'clock. So that's my concluding remark. You should be here. There will be coffee in the morning at 8:30 or 8 o'clock if you're being very enthusiastic. So we'll aim to start at 9 o'clock. And some of the speakers we will be filming tomorrow, so we'll try to catch you as well. And those who are attending for the speakers' dinners will get 7:30. You should have all received the address. I thank all the speakers that came and presented today, which was great, and the delegates that attended, and to the 49 people that are online, thank you for staying. And I wish everybody to enjoy some sunlight while it's there.
Kind of, I think important to Gruby Josek. So for speakers, information that in a city center in our Jan Paweł 27 Street, we will have a dinner, and the name is Gruby Josek. Yes, and don't worry, Gruby in Polish, because there was some kind of introduction in Polish. Thank you. Before, Gruby is fat, Josek is Josef. So there is an organizer. It won't be something that after the dinner we will look like a Gruby Josek. Okay.